Good evening. We'll start off this meeting today. We have a packed program ahead for the next 3 hours. So, welcome you all to this edition of this Tamil Nadu ASU monthly meeting. We'll start with we'll welcome our new president, Dr. P. Ganesh, to come around and give us welcome address. Proud man, sir, please.
Good evening, everybody. It gives me immense pleasure to welcome you all to our monthly meeting. And our ever energetic secretary has been trying to create different options for the postgraduates to get interested. So this time we have a different format for the postgraduates, whereby we are going to have a panel discussion by the postgraduates moderated by a hepatologist. And I really request the postgraduates to be here on time, because that is the first session always. And apart from the panelists, I see only a few handful here. So I request all of you to tell your colleagues to be here. So don't miss this panel discussion. It's been conducted in your interest only. And we'll start off with the first session. I request the postgraduate panelists to kindly come on stage. Vishnu Dev from Madras Medical College, Mona Majumdar from Stanley, Rijosh Sabu from Keelpok, Koti from SRMC, and Satvik from SIMS. I request the moderator, Dr. Vamsidhar Reddy, to kindly take stage and also take pleasure in inviting the chairpersons for the session, Dr. Prem Kumar from Hepatology MMC and Dr. Hema Mala. Thank you so
much. Good evening, one and all. For all the dignitaries who are on the floor, and also my chairpersons, and also the postgraduates present here. Today my discussion and job for me is for sail through for 1 hour regarding the PG clinics. So I have a real case scenario. So 43-year-old male with no comorbidities came with jaundice since 3 weeks, abdominal distension since 2 weeks, and reduced urine output since 3 days, and have some altered sleep pattern, and without any history of any fever, no bleed or no melena. So, and we have taken a history of alcohol dependence. It is more than 200 grams per day, and 20 years is taking, and case question is all positive, and the last alcohol around 20 to 30 days back. And the vitals, pulse is around 100, MAP is around 78, saturation is normal. And on examination, patient has ascites is there, and on probing history, patient has urine output of 500 ml per day. So in the investigations we have done, hemoglobin shows 11.5, MCV is of 105, TLC is leukocytosis is there with neutrophil of 88% with 19,500, platelets are 98,000. Ultrasound showed liver 16 centimeters with coarse nodular, spleen 13 centimeters, and ascites is there. Creatine, it is 2.8 with slight rise in the urea, 55. Sodium is normal and potassium is also normal. Ascitic fluid cells. So we have done a diagnostic tab. It was showing 120 cells with neutrophils of 60, and all the viral markers and autoimmune workup was negative. The LFT shows bilirubin of 20 with direct component of 16. And AST is more than ALT of 180 and 90 with alkaline phosphatase of 170, albumin of 2.3. And urine routine was perfectly normal. INR is 2.1 with prothrombin, PTA was 27% with prothrombin actual is 22 seconds with lactates level of 3.6. So question to, I think I'll start from 1, 2, 3, 4, 5 like that, because it's difficult to remember the names. So you can start from the right hand. So what is the syndromic diagnosis you are thinking of?
So my syndromic diagnosis will be acute on chronic liver failure, ACLF syndrome.
Okay.
And
so, what are the points favoring of acute on chronic liver failure?
Because he has a history of jaundice is there. He has a history of jaundice is there,
Okay.
and which is followed within 4 weeks. That is, within 1 week of onset of jaundice, he had a development of ascites as well as encephalopathy is there. So it fits in the APASL criteria for ACLF.
Okay, fine. So, next one. So, what are the thinking of acute and chronic events? If we say ACLF, because I had to still disclose the diagnosis. If you think of ACLF, so what are the acute component? What is the chronic component?
Maybe, sir, chronic event, he was having underlying chronic liver disease.
Yeah.
On top of that, because of his recent ongoing alcohol abuse, he got alcoholic hepatitis. Maybe alcohol was the precipitating event.
Fine. Any other factor you wanted to tell? Acute.
Sepsis was also there.
No, one is alcoholic hepatitis, that is accepted. The second one you are thinking of, according to the investigations, what I have said to you.
Infections and sepsis.
So, still infections is a possibility because neutrophils are high. That may be a part of alcoholic hepatitis also.
Yes.
So that we have to rule out for the
Yes.
culture, because I didn't tell you the culture still.
Cultures.
So that you have to do. Chronic, what you have told is chronic liver disease. Rather than telling chronic liver disease, you should be specific. Anyway, the symptoms are there, so you have to tell us cirrhosis only.
Cirrhosis.
Because the ascites is there, and jaundice is not a decompensating event, but we can take as ascites as a decompensating event. So you can directly tell us if cirrhosis is there, rather than telling CLD, which have a chronic hepatitis also is CLD, chronic liver disease. So it is better to tell as a you can go ahead with tell as cirrhosis.
Cirrhosis.
Okay. So what are the various definitions? What are the various definitions and how to assess your severity? Anyway, I will divide it. You can tell about the definitions. What are the definitions?
Okay. As per the APASL defines ACLF as an acute hepatic insult presenting as jaundice and coagulopathy complicated within 4 weeks with clinical ascites and or encephalopathy due to a precipitating event with a high 28-day mortality.
Okay. So whether this acute precipitating event was included in the definition or not?
A hepatic insult,
fine,
yes.
fine. So, and what are the other definitions?
EASL has defined ACLF as an acute deterioration of a pre-existing chronic liver disease due to an extrahepatic precipitating event. Mainly kidney failure has been considered as the most common, and with a 3-month mortality which is higher.
Almost around 15 definitions are there for the ACLF. Still, there are more number of definitions are coming in the 2025 consensus. Also, there is one more definition has come. So, the most commonly used in India, at least, is APASL or CLIF ACLF, one canonic scores. This was the definitions what we use generally. So there are other definitions is an ACCELD and also WGO type of is there, Japanese is there, Chinese variety is there. So but most commonly we use CLIF this canonic or APASL definition. So how do you assess the severity?
Assessment we look at the CLIF score, sir.
No, if you have to specific for the definition. So APASL definition what you see and canonic what you have to see.
Mainly we look at the INR values. Sorry.
So you can directly go to scores only. What score you will be seeing for an APASL definition?
So mainly we can go for MELD sodium score 1 to us.
Still. So for an APASL we have to say there is a specific score called ARC score, which is an Asia Pacific Research Consortium, which is called an ARC score. So that we have to use. And for a canonic CLIF ACLF scores you have to use. There are other scores, but I think these two are enough for this thing. And so what is the interpretation from this thing is there is a rapid progression. So from jaundice to whatever the encephalopathy interval is around less than 1 month, and the jaundice is looking like a hepatocellular jaundice, and SGOT is more than SGPT. And there is a synthetic failure which has been noted in terms of coagulopathy, and also there was albumin is also low. So an encephalopathy with an altered cell pattern, and I forgot to examination showed flaps also is there. So encephalopathy grade 2 we can consider. And the patient was also having a cirrhosis. What are the things? There was a ultrasound evidence of nodular outline, and also ascites is there, and also thrombocytopenia, which all suggest in favor of cirrhosis. And there is one more component, is AKE is acute kidney injury, and we have to decipher it which type of AKE. And there was a leukocytosis, and also maybe it can be a part of systemic inflammatory response, or maybe actual sepsis can maybe there, or maybe due to part of the alcoholic hepatitis itself. So what are the syndromic possibilities? So there is definitely liver failure. So liver failure can be either acute decompensation or an ACLF, like acute or chronic liver failure, or is it just a stable decompensated cirrhosis? So what are the favoring points according to this case? We can able to tell as acute decompensation also, because patient having acute insult, patient having rapid progression is there. And reversibility, one of the factor in acute decompensation, if it's due to hepatitis B, or if it's not taking drugs, we can able to use the nucleotides, and then maybe hepatitis B means the cirrhosis can be reversible also. There is a high short-term mortality because of the acute decompensation. If it's a ACLF, there's acute insult, rapid progression is there, underlying cirrhosis is there. With reversibility can also happen in ACLF, that I will be coming to the next slides. So, and also having very high short-term mortality. So that's why the definition, the distinct syndrome has come in the way back in 2000, first in the APASL group and then in the canonic group. Based on this high short-term mortality, they found a specific group having a high short-term mortality because of the immune paralysis and also having increased pro-inflammatory cytokines. Patient having, it is slightly behaving distinct from the acute decompensation. And the third is a chronic decompensated cirrhosis, is slow progression, and patient will have a end-stage cirrhosis. Generally, it is a irreversible disease, and having a short-term mortality will be there. So coming to, I'll tell about the studies according to the definitions, all the things. So coming to etiology, first we have to know what is the cause for the cirrhosis. So what is a common, you can only tell a common etiology. What is a common etiology? Worldwide, western side, and east, Asia Pacific side.
Our Indian data shows that alcohol is the common etiology.
Okay.
And overall, now NAFLD is the common etiology.
It's an emerging one.
Emerging
So
one.
Specifically, if I tell Asia, which is the common cause of the cirrhosis?
Asia, alcohol.
No. Asia, it is
NAFLD.
hepatitis B is the most common, because China and Taiwan, East Asian countries are having a more number of population than the India, and it accounts to hepatitis B is the most common. In India, it is the alcohol cirrhosis is the common one. So next is, if in India, there are two studies, major studies. One is from the Shalimar group from AIIMS. So they found that in 1,049 patients, alcohol was the most common thing. This was 56.7% accounts to that, almost half of the percent. And hepatitis B and C, it is 15.9%. And in the PJ group, it is 100 patients, Dr. Duseja et al. And has been studied, that they found that 61% have alcohol as a cause of the cirrhosis. So coming to acute precipitants. So what are the acute precipitants as a routine, not about the case. So what are the acute precipitants you know of? Maybe you can just combine both acute, means a canonic and APASL. Or you can separate each one and tell. So whatever is there, fine.
According to our consortium or APASL,
Yeah.
the acute insult should be intrahepatic, like alcohol-associated hepatitis is one thing, or it could be any hepatotrophic viruses, either Hep B reactivation or superadded infection could be one other thing, or it could be acute alcohol intake, not related to acute alcoholic hepatitis, or autoimmune hepatitis presenting at ACLF can be, or it could be a delayed event causing a ACLF. It has been, Buchieri has also been indicated in the newest Kyoto guidelines.
So can you tell about the canonic, what are the remaining acute events you can just enumerate?
Maybe it's a sepsis, any surgery, any
Fine.
trauma,
Yeah.
renal failure.
So coming to acute precipitants, we can broadly divide into infectious and non-infectious one. Infections, so you have just missed out main importance is a viral hepatitis. Viral hepatitis can also be cause of one of the acute precipitant, can occur in cirrhosis also. Like patient who are hepatitis E can be there, or hepatitis A can be there. That itself will cause the acute flare. The second, non-hepatotropic virus like EBV, CMV and varicella, or reactivation of the chronic hepatitis B, and maybe other infections affecting the liver and sepsis, but it is not actually approved in APASL, but recent Kyoto consensus in 2025, they have approved for sepsis is also one of the factor for the APASL group also. And non-infectious, definitely in alcohol and use of hepatotoxic drugs, autoimmune hepatitis flare, Wilson's flare, or any surgical intervention. That means any patient will be a stable cirrhosis. Maybe he has a HCC and we have done a hepatectomy. So patient can go into an acute acute and chronic liver failure also. And patient can also having upper GA bleed, which was included in canonic definition, not in APASL. So that itself will be one of the acute component. So we can also divide this acute component precipitants also, we can able to, like which is the most common in canonic group is sepsis, basically. Bacterial infections accounts to 30 to almost 1/3 cases. And actually almost 50% of cases will not be knowing the cause, it's almost cryptogenic. So in other 50% only will be, that 30% actually will be accounting the cirrhosis. Again, in Shalimar group has told that it is acute alcoholic hepatitis, actually 35% it is more common. And the second most is the viral hepatitis reactivation. Yeah. So this has been again deciphered into another classification by PJ group. So they have told us a type 1 non-hepatic and type 2 as a hepatic insults. So type 1, whatever you have enumerated already, sepsis, SBP, surgery, and some unknown factors. Type 2, it's purely hepatic, like acute viral hepatitis, drug or toxic, or alcoholic hepatitis, or hepatitis B flare. So the diagnosis is confirmed. So it's an acute and chronic liver failure. Whenever you write a diagnosis, you have to be like this basically. Acute should be a component of alcoholic hepatitis. Chronic should be alcohol-related chronic liver disease or cirrhosis. Jaundice, coagulopathy, ascites is there. Encephalopathy, we have to grade the encephalopathy. And the AK, we have to mention which type of AK, that I will be coming to the next slides. So which definition now? Everything is in our hands. So which definition it will be going? You wanted to put in APASL, you want to put in canonic, or you want to put in both, which will be better?
Canonic, AK is also there.
So, okay, fine. Okay, if AK is there, yeah. So it will actually fit into the two definitions basically. So APASL and canonic definition. So APASL, there are so many modifications are being going on because the same questions from the east and west, they have their clashes, and they're redefining the things. And the latest I have not mentioned, 2025, again a Kyoto consensus has been happened in the last month. So almost 4 revisions has happened. There was differentiated into grade 1, 2, 3, and the canonic in 2013 they graded into grade 1, 2, 3, and WGA group and grade type 1 and 2, 3. So why the concept of ACLF has come? So basically, if a normal liver has acute insult, so patient will have an acute liver failure. That is the definition for acute liver. Basically, patient should have a normal liver. So if a patient have a chronic liver disease, acute insult, patient having satisfying the definition between that 4 weeks, all these things. So jaundice interval. So that can go into the ARC-ACLF. And patient will have a repeated decompensations, like already have been decompensated or already known cirrhosis with some events like GI bleed or HE or ascites already occurred. On top of it, patient has developed one more decompensated event or one more acute event. Then patient can go into ACLF. That has been mentioned in the canonic group. So what are the main differences between ARC group and also canonic group is ARC group will have a homogeneous pattern because they have taken only hepatic insults as a thing, and they have defined very clearly according to the definition of the hepatic liver failure. But in a but canonic score, it is a heterogeneous group because they have taken all the events which can cause a acute worsening of decompensations. So maybe the extrahepatic decompensations, if the creatinine alone is high, everything is falls in the normal limit. Maybe bilirubin is normal, INR is normal. Even if AK is also there, it is actually falsely telling that the patient having a ACLF basically. So there was some heterogeneous groups there, and there was some disadvantage with the canonic group and also advantage with the canonic group, and there are also same thing holds with the ARC group also. So the sequence of events, the main thing is a golden window. So whenever the acute precipitation occurred, between the acute and also where there is a worsening of events, where the survival disadvantage will be there. So the golden window will be always in a days only. Generally it is mentioned as 7 to 14 days, but 7 days will take as in all the studies we have taken as 7 days. So patient initially they have an organ dysfunction, which will be after 7 days. If the event has not been rectified, the patient will go into organ failure basically. That will be part of parcel of definition of the canonic thing. So when you do some intervention in the organ dysfunction phase, patient can be reversed in that phase only. So that patient will not be going into the organ failure and ACLF. So patient, there's a new term called recompensation. Recompensation means the patient, whatever decompensated event has been reversed off. So I'll come into the next slide, sir. So that can happen. So that golden window, we have to catch the patient at that point of time, and we have to treat accordingly. So this is the same thing. So if ACL, if you see the steep slope, if that golden window is crossed, the patient mortality will be very high. But if you do something, the patient can have a spontaneous recovery, or patient can go for the liver failure, and maybe if the patient have a transplant prospects, then we can go directly for the liver transplant. Or if there is a terminology called futility of care. So I will be coming to the next slides. If the score is more than 64, a CLIF ACLF score, then we have to explain to the family attendants, and we have to just do the salvage treatment only. Yeah. So Apostle 2019, this is the definition: acute hepatic insult manifesting as jaundice, bilirubin more than 5, with a coagulopathy of INR of more than 1.5, with PTI is less than 40%, complicated within 4 weeks by clinical ascites and or encephalopathy in a patient with previously diagnosed or undiagnosed liver disease, and associated with a high 28-day mortality. See, diagnosed, undiagnosed, why they have told, there is a 2 components in this: autoimmune hepatitis and also having a chronic hepatitis B. This patient may not be having cirrhosis, but they have a chronic liver disease, which can reactivate by AH flare or hepatitis B reactivation, can also be standing in the definition of ARC-Apostle ACLF. So the grading, what I told, can you tell ARC what are the parameters? Anyway, you can also tell. Yeah.
ARC score includes bilirubin, INR, serum creatinine, hepatic encephalopathy, lactate serum.
So if you see that all the parameters are involving only the liver parameters are only there, so that's why it is actually homogeneous group. And if you that will only definition will be standing good with like Apostle ACLF. So they have been differentiated into 3 grades: grade 1, grade 2, grade 3. They have a 5 to 7 scores, and 8 to 10, and 11 to 15. If and they have a cutoff points less than 15, they have a given 1 point, 15 to 25 2, and more than 25, and same thing holds in all things. But lactates, they have given us like less than 1.5, and this is a more than 2.5. So why they have mentioned this is a grade 1 Apostle ACLF. The patient have 12.7% 1 month mortality will be there. Grade 2 it has 44, and grade 3 is 85. This almost exponentially is increasing. So if you rectify within that first week, the survivors will be increasing. If you are not rectifying with that first week, patient will have more of non-survivors. And there are studies by Chowdhury et al. Has told that cutoff of 9.5, if there is an increase in score of by 1, the 28 mortality will increase by 10.2%. So coming to the CLIF canonic score. Canonic score, it is observed in 13 and 43 patients in the 2013. They have defined as acute decompensation of cirrhosis, because cirrhosis has to be a part of the definition in canonic. Apostle, it is not like that. Maybe patient have a cirrhosis or chronic liver disease. Anything is okay for the Apostle ACLF. So an organ failure definitely has to be there, and high 28 mortality more than 15%. So the definition stands: acute deterioration of the pre-existing chronic liver disease, usually relating to the precipitating event, and associated with increased mortality at 3 months due to multi-system organic failure. So next one, CLIF's this canonic score. How will you? That's what I asked you last time. Scores.
Yeah.
How will you do?
So CLIF-C, mainly we look at the.
So what all the things you will be seeing in that?
Bilirubin, INR, then the other organ involvement which can be there,
Yeah.
like in respiratory, kidney involvement, and then the ascites part.
Ascites will not be there.
Ascites is not there.
Cerebral component will be there.
component will
So
be
there are
there.
6 components.
Circulation also.
Yeah,
will be
circulation.
there.
So 6 components: liver, kidney, brain, coagulation, circulation, respiratory. Based on that, they are having a grade. And if this a pink color notifies that patient have a organ failures. If a liver bilirubin is more than 12, or kidney more than actually kidney, they have a specific because kidney is a driving factor actually, which will actually denotes in a day-to-day practice. If the kidneys are good, maybe we can have some hope in the patient's survival. So if the kidney is around, creatinine is around 2, also we have to label it as an organ failure. And if it's a brain, it's a HE grade 3 and grade 4. In this case, it is not an organ failure, it is only the kidney and also the liver and coagulation. 3 organ failures are there. So it's a grade 3 ACLF according to the canonic definition. So this is the same thing. And here also see the mortality rate 4.7, 22, 32, and grade 3 is 76.7%. But in average in that study, they have found that is around 33.9%. So I hope so it will not be visible. So these are the major differences between APASL. The major differences will be the hepatic and extrahepatic. Second is the time duration. There is a 28 days. There is here it is 3 months. And main thing, sepsis is included in canonic. APASL has not been included. And other scores, it is different, CLIF-C, FCLF, and here it will be ARC score. And the golden window will be it is actually mentioned in APASL ACLF, it is not mentioned in the canonic score. And homogeneity, it is homogeneous in ARC group, and canonic group, it is not a homogeneous group. So coming to the, say if this is acute decompensation, if you think it is a benign or like it is a more than the benign, I mean survival rate is good or bad? Bad. Still, even acute decompensation also, we should not think it is a very stable. It's a stable stable cirrhosis is the only one which will have a good survival rate. All other things will have a unstable decompensed cirrhosis or acute decompensed cirrhosis, and there is a new component called further decompensation, which has been included in 2025. So these are the 3 will have a high short-term mortality if you are not addressing at the correct point of time. So AD develops in a patient with a chronic liver disease without prior decompensation, often associated with identifiable precipitant, and develops in less than 3 months. It is almost like ACLF, but patients will not have a organ failures basically. So it is short of pre-ACLF, you can tell. In AD, there are 3 components again. It is an stable decompensed cirrhosis, second one is unstable decompensed cirrhosis, and third one is a pre-ACLF. But most of the acute decompensation maybe will come into the unstable, where they will become admitted. It is based on the admission. If no admission, it is a stable one. If admission is there, unstable one. If the patient go into calculator, it is more than 60 with or without prior decompensation. And mortality is slightly more in ACLF group compared to the acute decompensation. Recovery will be happening in acute and chronic liver failure, because at that point of time, patient has some acute precipitant which has caused, if you control that acute precipitant, patient can go into reversal of cases in half of the cases. So this is already there with the known or unknown chronic liver disease. This may be the proper definition in the further thing, but still validation is required. So they have included, along with the canonic, the extrahepatic also they have been included, all the hepatic components holds on. So, and they have reclassified, because so many definitions again are there, so it is very difficult to remember the names, ARC, canonic, all these things. They have to divide into type A and type B. So type A includes all the APASL and Japanese, all these things. Type 2 includes, type B includes, is a ECell, NACCell, and this is COSH is the Chinese for the hepatitis B reactivation. So they are based on the scores, the same thing, B1, B2, B3. B1 is 1 organ failure, B2 is 2, and B3 is more than 2 organ failures. And A1 is 5 to 7, A2 is 8 to 10, and A3 is 11 to 50. So this may be, I think, in future maybe a simpler definitions for further in the cases. So what are the new terminologies which have been included in that studies? One is recompensation, one is ACLF again, one is a non-acute decompensation. So recompensation, what I have told you, it denotes on the removal or control of the etiology, resolution of the clinical decompensation such as ascites and HE, absence of variceal bleed, and sustained improvement in the liver function such as albumin, bilirubin, and INR, with or without use of beta blockers. This has been specifically told with or without use, because everything can be reversed. Portal hypertension still be there. So patients can use this beta blockers also. It is still, it needs a clarity of definition. But initially they told with reversal of portal hypertension also, then that cannot be validated in all patients, because patients on beta blockers can be there. So the driving factor will be the portal hypertension. So that they have again modified this definition with or without use of beta blockers. Second is ACLF again, the patient has a ACLF, recovered, recompensation occurred, and again one more acute precedent, maybe reactivation of alcohol intake or hepatitis B medicine, they would have stopped the medicines again. So patient can go into ACLF again. The term period they tell as ACLF again only after 12 months. Like a patient has recovered back after 12 months. If the patient has again ACLF, we'll tell as a ACLF again. If the patient before 12 months, we'll continue to tell as ACLF only. So non-acute decomposition, this is a new terminology has come on. It is describes a more gradual form of decomposition which symptoms develop slowly, often without the need of immediate hospitalization. It is almost equal to the stable decompensated cirrhosis, which case other term is called non-acute decompensation. So again, coming to diagnosis, so it fits into both APASL and canonic definition. APASL is a grade 3. The score comes to around 13 with a lactates of 2.8, bilirubin of more than 15, and INR is more than 2. And canonic grade, I told all liver, renal, and coagulation. CLIF CACLF score is 58, MELD is 38, and MDF is 51. So you know the acute factor, you know the chronic factor, you know how to prognosticate the patient. Now coming to the slightly into the management part. So can you tell about the natural history of alcohol-related liver disease?
So the patient in compensated state, generally to decompensate without any underlying precipitating factor, it will be around 10 years for a compensated cirrhosis to progress to decompensated. Once they have reached a stage of decompensated cirrhosis, the median survival will be 2 years once they reach the decompensation.
Yeah. So
others, if there is any ACLF or any other thing, still the survival even more
So
drastic.
second question, definition of alcoholic hepatitis. Anyway, I'll tell all the things, but you can just definition of alcoholic hepatitis.
It is being defined according to the NIAAA criteria. Like the alcohol intake should be there with abstinence should not be lasting more than 6 days, and the jaundice must have occurred within 60 days,
60,
and the jaundice should have happened within the last 8 weeks. With ALT, AST should be more than 50 and less than 400, with the ratio being more than 1.5, and excluding other factors of causing the same picture.
So in this patient you tell, as a overall also you can tell.
We can sort out if there is any neutrophilic infiltration and also steatosis along with the background cirrhosis, then we can give a trial of immunosuppression for this kind of case.
Which immunosuppression?
Yes,
corticosteroids. Which immunosuppression? Corticosteroids only. Okay.
We can differentiate between AH, ACLF and severe acute alcoholic acid, because ductular reaction and other thing will be more in there.
So there are some specific points which will be having a favorable etiology, but not in favorable. Whether we really need to do biopsy, I will be coming to the next slides. So what is the anyway, management of severe alcoholic hepatitis? I'll ask you in the next slides. So if you see this, already you have told the definition, significant alcohol use. This you didn't tell. Significant alcohol use is the women who are having 8 or more drinks per week, with men of 15 or more drinks. It's simple, like it's a MASH criteria. What a new criteria is criteria is there. If it's crossing more than 14 drinks in a male, or in as a female, it is a more than 7 drinks. Basically, they are made into one more than equal to in the this thing definition, and here it is like 8 and 15 they have told. So regular heavy drinking, women more than 20 grams of pure alcohol per day, with men of more than 40 grams of alcohol. Binge drinking is 60 grams of pure alcohol or 5 more of standard drinks in a single sitting. This time duration is very important. It's not the drinks what we drink, it is the duration is important. In this, it should be in less than 2 hours. Okay. So if you have told all the definition of NIAAA criteria, onset of jaundice within prior to 8 weeks, an ongoing consumption of alcohol, and with aspartate of AST of more than 50 and less than 400, and ratio should be more than 1.5, serum bilirubin should be more than 3. And with a liver biopsy confirmation, if you do, it's a gold standard one. We can able to tell it is a definite alcoholic hepatitis. If you are not doing, it's only clinical and biochemical, it is called a probable. If it's a patient having possible, we have to tell it's a clinical or biochemical. So coming to management, so whether you use steroids for the alcoholic hepatitis or no, you have to tell in both. Like you have to tell as a stable alcoholic hepatitis with a severe alcoholic hepatitis, and also in ACLF whether you use steroids or not.
Sir, once we diagnose severe alcoholic hepatitis, depending upon the scoring system, and if there are no other contraindications for steroids like AK, bleed, pancreatitis, or infection,
whether these are relative contraindications or absolute contraindications.
not
So
sure.
currently mentioned as relative, but we can, because we generally use as a lesser corticosteroids in the alcoholic hepatitis, so we can take as a major contraindications only. Yeah.
And we can start with prednisolone
Fine.
food, and after 7 days we can calculate the Lilly score. The Lilly score, if it is less than 0.45, then you can continue
Okay.
for total of 28 days. If it is more than 0.45, then there won't be much role of continuing steroids.
So this all happened from the major trial in NAGM published, so STOPA trial. So they have been found that prednisolone, they have a there was some high short-term survival rate will be better. When you compare to 90-day survival, it is less, it is not there. So that time it has been found that actually steroids will be helpful in alcoholic hepatitis. So in the pentoxifylline, in the subgroup, they have found that although AK is slightly improved in some people, but as the overall survival rate is not there. So steroid versus placebo, non-significant survival advantage at 28 days with prednisolone with no medium long-term benefit, but pentoxifylline placebo, no survival advantage has been found. So, but in data in ACLF is still lacking, but there are some studies along with plasma exchange. In the shorter studies in CMC Vellore, they have found that some steroids with low-dose steroids with plasma exchange has found to be useful in recovery of the patients of alcohol-related ACLF. So, multiple contraindications, particularly sepsis, these are very notorious. ACLF are very notorious to get fungal infections, severe bacterial infection, multi-drug resistant infections. So, there are multiple contraindications are there. And third is role of steroids in ACLF is still unclear. Basically, nobody has done the randomized control studies and still the data is lacking. So coming to the second question, liver biopsy, it's always a challenging question. So if patient is patient stable cirrhosis, I will definitely go for a biopsy. If the patient having a decompensated cirrhosis, expenses, complications, and whether we can able to manage the patient based on the biopsy is again a question. So all these things will be there, should be individualized, not routinely done. TGLB is the preferred route because having the ascites, if the patient bleeds, they will be difficult to manage it. Utility is we can able to find the acute injury, chronic injury, stage of fibrosis and prognosis. Maybe used in certain situations, this is the answer I am expecting. If the patient having autoimmune hepatitis or Wilson's plate, definitely whatever is the thing, we have to do a biopsy. Further going to steroids or further managing the Wilson's, whether to go for transplant or thing. So we need a biopsy in a place where biopsy can be done. If it's not being done, then it's okay. But in a place where biopsy can be done, we have to do a biopsy in these conditions. And even in ACLF, they all in a cirrhosis without a compensation cirrhosis, a fibroscan will have its own value. But in a decompensated cirrhosis, having the patient having ascites, massive ascites with volume of 20, 25, like that, whether this really the fibroscan works is still questionable. So what are the poor prognosis master markers? What we find in this liver biopsies, ductal bilirubin status, extensive necrosis, like in AH flare, what we see is typically see, and eosinophil degeneration in a patient of drug-induced liver injury, advanced fibrosis with nodule formation, marked ductal proliferation, mallory-hyaline bodies, and pericellular fibrosis. All these things are the poor prognosis. If is a patient having a prominent hepatocyte balloon degeneration, cellular coalescence, mild fibrosis, a lower necrosis, patient have a better prognosis. So coming to, so I'll just enumerate what has been written here. So if the patient having alcohol definition, everything is a suspect alcoholic hepatitis, we have to calculate the MEL score. It is not only the MDF score, it's a MEL score is also important. If the MEL score is more than 20 or MDF is more than 32, we have to label him as a severe alcoholic hepatitis. And we can suspect that alcoholic hepatitis, and then we can start, we can do the liver biopsy in the places where it is possible. If it's not, it's okay. So then we have to start on prednisolone, and there's various protocols. Generally, we all follow 32 milligrams will be following, 40 milligrams. So 32, if the patient having IV methylprednisolone, we can go for 32. So then we'll see, and then we'll be reassessing a Lilly score after day 7 based on that complete responders, partial responders, and no responders. And no responders, definitely we have to go for further treatment strategies. If it's a complete responders, then we have to taper off the steroids within 1 month. And what is the role of other adjunct things? Is the N-acetylcysteine. We can use it because that has been studied and they have some survival advantages there. And metodoxin also having a survival advantages there. So we cannot use as a monotherapy. We can use as an adjunct along with the steroids. So, and this is a recent Abby Phillips from Kerala. So this 2024 is recent review article. It has been approved, still is none basically. So whatever we got from some studies with survival benefit, we are still going on with that. No benefit, not recommended. UDCA, N-acetylcysteine, vitamin E supplements, pentoxifilin, silymarin, growth hormones, GCSF. I mean, so this is a survival advantage I'm telling. So this nothing is there. So recommended, it is a corticosteroids, oral prednisolone, 40 mg once daily for 28 days. Intravenous methylprednisolone we can give 40 mg once daily. Switch to orals whenever it's possible. And long-term benefit definitely from the liver transplant. And long-term benefit experimentally still is FMT. FMT still is only 3-4 centers that are actively doing. One is in South, is in Kerala in Rajgarh College, and also in ILBS they are still doing. But rest of the centers I feel I don't think they are doing an actively FMT. So survival benefit in short term, corticosteroids and corticosteroids N-acetyl. And maybe N-acetyl we have to use, if a patient of severe alcoholic hepatitis, we should not add like 600 mg BD like that. It should be as a ALF dose only basically. So we have to use the same ALF dose, and maybe we can use metodoxin as adjunct to the corticosteroids. So this is short notes on FMT. Basically, they will select the proper donor. They will do in a research laboratory what are the microbiota, which is all these things happens because of a gut dysbiosis. So there will increase permeability and the endotoxemia can occur. So all these things will happen because they want to try at the root level. So they will take a donor which is having a favorable taxa, which organism taxa, and that bifidobacterium, if the patient have, it will actually bifidobacterium is better, and so it is a good bacteria. And if they have found that if after FMT there will be increase in bifidobacteria, and survival rate is also better, and HE also is improved. But these are all in a short studies and short like sample size. So we need a bigger size to know whether FMT is really helpful in alcoholic hepatitis. So acute component, we have stopped anyway. Patient will not drink alcohol in the ward. So acute component somehow we have managed it. So what are for the chronic components? What all we have to do? So whether nutrition is helpful in cirrhosis, in alcoholic cirrhosis.
Yeah, protein intake is mandatory.
And how much you need to clarify, like how much you have to use. What is the, so if the patient comes to an OPD, what all the therapy will give according to nutrition?
So we promote the nutrition mainly by increase the protein intake, and restrict the fluid diet, and also we advise them not to take off any like daily, go for any other medications like CAM intake, and then.
So and rest AKA staging and management. Can anybody tell? No, I know it is a difficult, but you can just enumerate what is AK definition. Rest of things I will tell.
Apasal generally they differentiate as AK and non-AK, and non-AK AKD CKD. In
Apasal is differentiated, or what is the society name? IC. It is ICA, International Club of Ascites, which has defined the AK in cirrhosis. Yeah.
And AK generally stage 1, 2 and 3.
Okay.
Stage 1 is creatinine more than 50% from the baseline.
Okay.
Stage 2 it is more than twofold increase in creatinine within 48 hours. 3 is more than threefold increase in 48 hours.
So HE, what are the axes of HE, if anybody knows? Anybody can tell?
Types, type A, type B, type C.
Okay.
Type A is an acute liver failure. Type B is some portosystemic bypass other than intrinsic hepatic injury. Type C is cirrhosis, chronic liver disease. Then episodic, recurrent and persistent. Then spontaneous and without any precipitating event. Then covert and overt HE.
Yeah. So, for answer to the first question, prevalence of malnutrition, sarcopenia and ACLF. Malnutrition is very frequent, almost 20% of the cases in compensated and more than 50% in decompensated cirrhosis. CTPA, as the CTP scores increase, grade increase, and the sarcopenia also will increase. And severe in alcoholic liver disease, patient will have a severe wasting and the sarcopenia can develop. Both adipose tissue and muscle tissue can be depleted, but most of the adipose tissue, if you see in females, it is adipose tissue. It is in the males, it is the muscle tissue will be depleted. So malnutrition, muscle loss has been often we can able to see with the BMI itself, with the equivalent of severe malnutrition. In some cases, we require a further scoring, And why we need a sarcopenia is important in ACLF is a higher complications, higher infections in post LT also, outcomes will be poor. So, is there any benefit of tailored nutritional therapy in cirrhosis? Definitely yes. And I have answered the question. So, definitely yes. Is there any role of protein restriction? Definitely. Previously, they almost 20 to 30 years initially in the late back in 1950s to 60s or 70s, they found that the protein, if you take more of HC will happen. But later, some landmark articles has been published, which has found that even its depletion, if a restriction of protein causes a very rapid deterioration of the HC, and as a overall cirrhosis also, and thus the protein matter. So vegetable or dairy protein, still there was some consensus saying that vegetable protein is always better than the animal protein. So see, generally what we keep in the wards is we'll keep the overnight fasting for a CT scan, but we have to know that overnight fast in a cirrhotic patient is equal to almost 3 days, if almost 2 days basically, of a routine normal individual. So because there is a catabolic state, so much of fuel homeostasis will be occurring there. So there will be carbohydrate oxidation, increased fatty oxidation, negative respiratory quotient, proteolysis will be happening. So we should be judgmental in patients keeping overnight fasting for any procedure or the, we have to really, when the procedure will happen, we have to think of a nutrition we have to give almost as equivalent to a management of the routine medical management of the patient. So this study has come from 2008. So 103 patients of cirrhosis, they found daytime and night time. So they actually given patient late night snacks, and then they have done the study. They found that more of a total body protein has been increased, and free snacks, it's a reverses aberrant substance utilization pattern, improves the nitrogen retention, and may improve quality of life and survival, may reduce the frequency and severity of HC. Recommended is calorie protein should be, we have to take multiple small frequent meals, higher protein content of the breakfast, and energy dense late evening snacks is always, nowadays people are telling late night snacks also will be definitely helpful in a patient of either in a HC or in a patient of cirrhosis. So they found this is the landmark article for Moreno et al. So I'll just tell. So in this study, actually, they have done patients who are having a control arm and intensive nutrition arm. In a control arm, they have given less than 21.5 kilocalories per kg per day. In a intensive enteral nutrition, they are given more than 21.5 kilocalories. So that is the basic cutoff. The patient should, if the patient having less than 21.5 kilocalories, if the dietitian comes to rounds, if you have to see that is there. If that is there, we have to ask the dietitian to increase the thing if she is doing wrong also. Okay, so that is a minimal calorie intake, and anyway, 30 to 35 kilocalorie per kg per day is the recommended for the alcoholic hepatitis. So is the role of any protein restriction? Definitely protein restriction, previously 1950s, 1960s, definitely they have a protein restriction, but later studies has been told that if you restrict the protein, there is there may be worsening of decompensation of the, and overall survival rate also will be decreased. So no protein restriction is recommended, no protein restriction is recommended in cirrhosis with patients with cirrhosis and HC. Protein restriction is rather detrimental in cirrhotics. So coming to the next question is the vegetable matter or the animal protein. Vegetable matter, they have a low levels of ammonia producing amino acids like methionine and aromatic acids like tryptophan, phenylalanine and tyrosine. And they have a crossover comparison study they have done. They found that vegetable protein have improved nitrogen balance and clinical grading of HC, and having abundance of dietary fiber helps in eliminating the intestinal transit time and increase the intraluminal pH and the fecal ammonia excretion. So this is the cirrhosis and advanced liver disease. If a CTP A on C, what we have to first measure it. According to it, we have to calculate, at least not in a busy OPD, we can at least calculate the BMI. Even if non-busy OPD, or if the dietitian is a part and parcel of the OPD, we have to have a separate scoring system like SGA and Royal Free Hospital Global Assessment. And then we have to classify as a no malnutrition, malnutrition, sarcopenia, and the nutrition supplements has to be given from the dietitian prescription accordingly. So the final take is dietary intake of critically ill cirrhotic patients is not lower than the recommended 35 to 40 kilocalories, and 1 to 1.5 grams of protein per day has to be given. So always the trace elements has to be taken in role. Zinc has to be given, and magnesium, all this, and vitamin D, all these things will be low in cirrhotic patient. We have to be supplementing them with this thing. If the bilirubin is very high, so we have to give the ADEK, because they're all deficient in cholestatic diseases, so we have to give supplement that also. Hepatic encephalopathy, BCCA enriched solutions, still data is lacking, whether it have a survival advantage or whether short-term HE definitely it will improve in acute liver failure we have seen, and also in decumbent cirrhosis we have seen that IV LOLA has been better, but as a routine BCCA in OPD basis, whether it is improves the HE, still a questionable debate because of the cost is the main factor, so we have to see. So always enteral nutrition is always the best thing. If at least by mouth, if they are not having that, at least we have to give Ryle's tube. If at least the calorie intake is very poor, based on at least 72 hours, then we have to at least switch over to TPN. So coming to the case again, I'm talking regarding the AKI now. So albumin has been injected. Anyway, albumin will be giving in a cirrhosis patient with ascites. We are given as per the guidelines. Because there are various guidelines, it can be given on an individual basis, because we cannot go to that high doses of albumin as prescribed in the guidelines. So maximum we can go 40. I have not gone until 60. So one patient I have gone until 60. So generally I'll limit myself to 40 grams per day in a day. So we have given the albumin and excluded all the pre-renal measures. Still creatinine is 2.6. So from 2.4 or something, it's almost the same. Basically, it is not improved. What to do next?
Either we can start on a vasoactive agent.
Okay.
Concomitantly, we can rule out an intrinsic cause of AKI by doing.
Okay. So next question, Donna. So how will you classify AKI as a general, not in cirrhotic, as a general? You can tell.
Sir, pre-renal, renal, and sometimes it can be obstructive post-renal also.
See, if you have pre-renal, it is almost in cirrhotics. If you take pre-renal, is almost 50 to 60% of the cases it accounts to the pre-renal AKI. Some patients, like around 30%, will be the ATN. Basically, is a per se related to the kidney, and some there is a functional AKI, is a structural functional AKI called an HRS. That accounts around 20%. And around 1 to 2%, I've seen only one patient of having a bladder clot, so can have a obstructed causes of this AKI. So coming to pathophysiology, there are so many definitions, NACI, AKI, so many definitions has been coming. So I'll just clarify some of the things. So I think recent ICA, IDQI criteria has been come in 2024. So that's what we are following the definition now. So in a patient of cirrhosis and hypertension, the patient will have a splanchnic arterial vascularization, and also there will be increased RAS activation will be there. So with that, patient will have a renal arterial constriction will be there, so that the GFR will be decreased, and the patient will have a decreased urine output. This is the basic pathology for the AKI. So based on the if there is no functional, no structural AKI, then we can tell non-NKD, and if it's a functional change is there, HRS AKI. If it is structural, there is ATN or ATI, and if it is a functional plus structural is there, some patients it is not, pure functional AKI is definitely not possible, but for definitions we have to go ahead. But there will some definitely, if you go ahead with the biopsy with all the patients, there will some structural changes also will be happening. So if both are there, then HRS AKI plus ATN we have to tell. So this is the new diagnostic criteria. There were so many revisions are there. Previously, if you see the first one only, previously the good old way I have done my 4 or 5 years back, it is only the cirrhosis with ascites, the patient having HR. Now it has been defined in cirrhosis, acute liver failure, and also in chronic liver failure. Anything patient can develop what are the other further criteria is fits in. So we have to call as a hepatorenal syndrome. So increase in creatinine more than 0.3 milligram per deciliter within 48 hours, or more than 50% from the baseline value, or urine. This is again new component. This is not there in the previous one. Before 4 years, 5 years, it is not there. So it is a urine output is because it is very difficult in a day-to-day practice to know what is happening. So we have to check for more than 6 hours. If it is 0.5 ml per kg, it's less than that. Then we have to think in a hepatorenal syndrome. And there's no full or partial response even after 2 days with of diuretic withdrawal or all the pre-renal causes. If we remove it also, and after giving albumin also, patient has not improved, the creatinine has not been improved, then we have to call as a hepatorenal syndrome, and patient should not have shock. And this is a slightly dilemma condition. So some patients can have a sepsis also, can have a HRS also, which will respond with terlipressin. Some patients, but according to definition, if the patient have a shock, we have to exclude that as a HRS. So no current or treatment with nephrotoxic drugs like aspirin or the other DILI, whatever is there. And absence of strong evidence of in the urine routine. That's why I told in the first urine routine is normal for this patient. And there's no RBCs, there's kidney ultrasound is normal. And urinary biomarkers, if is available, then we have to, but still the question is debatable. Urinary NGAL, urinary cystatin, K19, all these things, whether we have to do as routine practice, still no, but for research purpose, definitely yes. So, and what are the other things which we can do day to day is what I feel is a fractional excretion of sodium. This is an easy test available in almost all the hospitals. So this if we do, it is less than 0.1%, then we think that we are dealing with the HRS rather than the acute ATN. So terlipressin with response, the way back in 2008, they found that treatment was Arun Sanel et al. They found that there was a treatment success is there. I'll come to a definition what is success, what is a treatment response, partial response, all these things. So they found that HRS reversal was found in 19 patients with 12.5%, 0.0, and this is a significant one. So serum creatinine has been improved, and but survival rate still survival advantage was not there. So what are the outcomes actually AK will have? So patient have a exposure, patient have no kidney disease, or AKA can happen or CKD can happen. And when exposure happen, then patient have a complete recovery, for AKA can develop, and they go into complete recovery, they can go into partial progression, and the patient can go directly into, they can go have a death, or patient can go into dialysis, and then maybe patient can have a partial recovery, then maybe it can progress to CKD, or patient can have maybe liver transplant can be done, and then patient can be, survival can be achieved. So acute kidney disease is less than 90 days, and chronic kidney disease is more than 90 days. In acute kidney disease, there are two components: acute kidney injury, which is less than 7 days, is with increase in serum creatinine of more than 0.3, and we need to know the baseline. Baseline, again, there are multiple definitions. What we take is whatever is the best possible available we can take. At least for 7 days is the best thing. If it's not available, whatever is available. Some people will take 1 month, can be taken for 3 months. But in routine practice, we can take at least for 3 months, it is valid. But because we don't know, but 12 months before it is normal, we cannot able to predict whether it is if a patient having uncontrolled diabetes will not be knowing whether it is a real baseline creatinine or not. So at least for 7 days to 1 month to 3 months, it is okay. But whatever is available, if nothing is available, whatever available creatinine, we have to take as a baseline. So urine output less than 0.5 mg per hour for 24 hours, so for more than 6 hours. So there is two things: adaptive repair and maladaptive repair. Adaptive repair, patient can be reversed. A maladaptive repair, which occurs in the pathogenesis within histology, when the patient can go into bad HRS and also CKD component. So this is again a busy slide. So I'll just tell you. So the patient of AKI, we have to take the history and physical examination, and we have to do the whatever test I told, ultrasound and urine routine. We have to see for the pre-renal causes, all the things, and then we have to label him as a pre-renal, renal, and post-renal. In renal, there are two things: AKI and HRS AKI and ATN. In a pre-renal, we have to give albumin. If there is giving more laxatives, we have to stop the laxatives. If the area can be settled, if the more diuretics are being used, we have to stop the diuretics. We have to see whether it is improving or not. So if intrinsic injury, we have to can send the biomarkers to know what type of thing, and then we have to label accordingly and then manage accordingly. So if the patient presented with HRS AKI, so they straight away go for the vasoconstrictor. So what are the vasoconstrictors, you know? Second. So what all vasoconstrictor activations we can use in cirrhosis, in ACLF with this thing?
we can use vasopressin agents like vasopressin agonists like terlipressin.
Yeah.
Or else, if terlipressin is not available, we can use norepinephrine. If both of these ICU backup actually. So if both are not available, along with albumin, we can give either midodrine along with which is alpha agonist.
Along with midodrine, anything you want to add?
Octreotide we'll add.
Octreotide, fine. So these are the routine vasoactive agents, whatever I has told, correct? In ICU setting, definitely in terlipressin, albumin we have to use.
Dr. Vamsi,
Always.
Dr. Vamsi, just for the lack of time, we have only 5 minutes
Fine.
more. Okay.
So we have to use vasoactive agents. So ACLF with AKI, and this is a recent one. So there's no shock. We have to see, and we have to see the biomarkers. The functional AKI, 6-hourly IVC assessment is called POCUS, point of care ultrasound, and monitor the MAP, notebook creatinine, AKI persistent progression. We have to see the IVC collapsibility. Based on that, we can take a decision. But generally, this terlipressin at 12 hours still is debatable. So generally, the guideline says 48 hours. So we can wait at least for 24 hours to early start terlipressin. And then we have to see the response. So under which category? Definitely it's an HRS mostly. And how do you manage this patient with an vasopressin, in terlipressin? How do you titrate the doses? Again, this is a question. So we have to increase the every 2 milligrams every 48 hours. We have to see if the creatinine is decreasing the less than 25% of the baseline, then we have to increase the components. So criteria for discontinuous terlipressin, definitely any side effects like diarrhea or patient will have a cyanosis of the thing, cyanosis of the limbs. Basically, then maybe patient have a cardiac arrhythmias, so we have to stop it. Criteria for and predictor for non-negative response: high creatinine value, high MEL scores. Patient who are having nil output, they will not respond much to the terlipressin. So indications of RRT in HRS-AK. So it's a patient who are having routine indications of dialysis plus patient having HE or severe grades of HE or as a bridge to the liver transplant. In these cases, we can use RRT in HRS-AK. So coming to access, you have already told the same thing: grade, time course, and spontaneous. So this, I think, primary prophylaxis. There's only prophylaxis of HE because we see in routine prescriptions will give all the patients with lactose. But generally, what guideline says, primary prophylaxis only in 2 events. One is in a TIPS, one is in upper GI bleed. In these 2 patients only, we have to give the prophylactically anti-HE measures. Other patients we have to give secondary prophylaxis only. The secondary already first episode has been already crossed. Then we can add rifaximin. So role of ammonia, always ammonia is not it's a central role, but it's very unclear role in this thing. We should not do ammonia as routinely because it changes with overnight meals, it changes with the fasting, and we have to see any bleed happen, it will be problematic. Or if any fluid challenge also given, we should not be doing ammonia. We have to give a time for ammonia to resettle, and then we have to do it. Coming back to our case, patient has been treated, creatinine has been normalized, and patient have what is the treatment of, still the MEL score is more than 30, what are the treatment option, whether to go for a LT or not. So according to the ACLF guidelines, so according to the ARC guidelines, we have to go for this patient because he has 13 initially, and by day 7 it has been recovered by 2 points. So still supportive management, still we cannot, means the patient still having a score of more than 11, so we have to go for liver transplant or maybe artificial device we can see. Artificial devices, there are 2 types of ALS and BALS. So the most common we use is the plasma exchange. Plasma exchange, just it is a temporary bridge. It will remove the inflammatory cytokines, and we have to take care of all the plasma exchange. What are the precautions? So we have to rule out infections. We have to proper consent to be taken. Citrate toxicity can happen. Main thing is trali and TACO can happen. So that is the most detrimental for the patient. So whether centrifugal and membranous, it is always a centrifugal which is better compared to the membranous. So complications, line related or transfusion related can be happening. So this I'll skip. I'll just go for
Can
transplant.
you summarize and what was the treatment? What
Yes,
was the
sir.
outcome in this patient?
Yeah. So when to this patient went to transplant, so this patient has not gone into futility of care. Still it is recoverable. It is not gone. The scores has not gone for more than 64. So, and ARC score has also, it is not, it is decreasing trend. So we have before going, we had transplant the patient. Before going for transplant, we have to know, this is the main thing. So we have to rule out when not to transplant: active alcohol use, respiratory failure, significant comorbidities, uncontrolled infections, or futility of LT is like Cliff cell for more than 64 and more than 4 organ failures. Definitely we have to stop it. So to summarize in LT, assess all patients for LT. If the scores is more than this, then we have to show significant comorbidities or uncontrolled infections and more than futility of LT is has to be 4 organ failure, refractory shock, we should not go for transplant. And this is the first, this is the study which will be coming in the years. So this is the one which will help you that even in higher grades of ACLF, whether we have to go for a transplant or not. So this is a randomized control trial, still recruiting is going on. So last slide. So what is the LT indication for alcohol-related ACLF is same as other etiologies or not? It is not so easy in alcohol because they can have a recurrence, re-abstinence, abstinence means recidivism can be happening. So alcohol is acute and serious presentation. Liver transplant increased recognized as the early accelerate H trial, which tells that we have to do early as possible. But at least we can keep that 1 month because 6 months is the actual rule. But for the recovery of the liver, for to know definitely he will be abstinent from the liver, alcohol. But at least nowadays people for LDLT they are waiting for one month minimum for getting into that transplant. So, and these are the studies which has been done. They have found that almost 20% have relapse rates post-transplant. So, we have to be properly see. And early LT, corticosteroid non-response, high MEL score more than 30, age more than 45 years. And in DDLT, there is younger age and severe relapses can happen prior to LT. And pre-LT smoking and substances, they have a higher risk of alcohol recidivism will be there. And we have counsel for LT, session of Plex, one session of Plex was done to bridge that. LDLT was done, doing 18 months of follow-up. He is a sarcopenic patient who was there and he has been improved. So take home message, ACLF is always a dynamic state, utilization of the golden window, early intervention and management of precipitating factors, prompt recognition and nutritional organ-based supportive care. This should be incorporated in all the bedsides and consideration for the liver transplantation in eligible patients. So, World Liver Day is coming, so this year theme is food is the medicine. Yeah, thank you.
Thank you. Thank you, Dr. Vamsi, for the extensive presentation, and you have covered alcohol-associated hepatitis, ACLF, and complications and management of the complications. And panelists, I think you should have an active participation, and only the moderator was speaking a lot, and they had a lot of presentations.
I think the time is short, but we can take 1 or 2 questions. No, we'll close. Okay.
Well, thank you.
So we'll close. Thank you, panelists.
Good evening, everyone. I'm Dr. Anna George from Apollo Hospital, Chennai. I'm presenting a journal scan on luminal gastroenterology, review of recent publications from India. My guide is Dr. Karthik Natarajan. So first study was spectrum of esophageal manometry and 24-hour pH impedance findings in non-erosive gastroesophageal reflux disease and response to phenotype-based treatment, a prospective observational study which was published in Indian Journal of Gastroenterology in Jan-Feb edition, and the study was conducted in Jipmer, Puducherry. So the background and objectives, GERD is categorized into erosive reflux disease and non-erosive reflux disease. NERD is further classified into 3 phenotypes, that is true non-erosive reflux disease where there is abnormal acid exposure time and symptom correlation. Second is reflux hypersensitivity. There is normal acid exposure time but there is symptom correlation. And the third is functional heartburn where there is normal acid exposure without any symptom correlation. So the aims of the study were to analyze esophageal motility and 24-hour pH impedance findings in NERD patients and classify these patients into NERD subtypes based on these findings and assess the treatment response based on phenotype specific therapy. So the flow of the study was like, it was a prospective observational study. The baseline demographic characteristics of the patients were recorded and symptom severity score was calculated. After that, all the patients underwent upper GI endoscopy. Patients who had endoscopic evidence of erosive reflux disease were excluded, and NERD patients underwent esophageal manometry and 24-hour pH impedance, and based on that they were classified into 3 subtypes. And true NERD patients were treated with high dose PPI, that is omeprazole 40 mg twice daily, and reflect these patients were followed up. The total number of participants were 53 patients and the primary outcome was symptom improvement at 3 months. So these are the baseline parameters of the patients. In that, heartburn was the most common symptom, and chest pain was the most common extraesophageal symptom. So the results, baseline esophageal manometry and pH impedance characteristics. Low esophageal gastric junction contractile integral was found in 60.4% of the patients. Ineffective esophageal motility was found in 53% of the patients, more common in functional heartburn patients. And acid exposure time, the median acid exposure time and medium Demister score was higher in true NERD patients as compared to reflex hypersensitivity and functional heartburn. And differentiation between NERD phenotypes, the distal mean nocturnal basal impedance, which is a measure of mucosal integrity of the esophagus, was found to be lower in true NERD patients as compared to reflex hypersensitivity and functional heartburn. They have also suggested a cutoff of 2376 ohms to accurately differentiate between true NERD and functional heartburn. And they have also assessed post-reflex swallow-induced peristaltic wave index, that is PSPWI, which was found to be lower in true NERD patients compared to other groups. And they have also looked for proximal MNBI, which was found to be lower in GERD-associated cough, so suggesting its role in diagnosing atypical symptoms. Treatment outcomes, 94.3% of the patients showed significant improvement after phenotype-specific therapy. Best response was seen in true NERD patients who were treated with high-dose PPI and also in reflex hypersensitivity patients. Functional heartburn patients had the least improvement, requiring long-term neuromodulators. So strengths of the study, it was the first Indian study using pH impedance for NERD subtyping. Prospective design of the study was a strength. Limitations were they had only a small sample of 53 patients and no long-term follow-up was done. Next is peroral endoscopic myotomy, short versus long esophageal myotomy for achalasia cardia, a randomized controlled non-inferiority trial which was published in Surgical Laparoscopy, Endoscopy and Percutaneous Techniques. Study was done in AAG, Hyderabad. Background, the optimal esophageal myotomy length for POEM in achalasia cardia patients remain uncertain. So the aim of this study was to compare clinical efficacy and safety of short myotomy, that is less than or equal to 3 cm, versus long myotomy more than or equal to 6 cm in patients with type 1 and type 2 achalasia. Methods, it was a single blinded randomized controlled non-inferiority trial. There were 54 participants, type 1 and type 2 achalasia. They were randomized into short myotomy and long myotomy groups, 27 patients each, and the primary outcome was clinical success at 1 year, that was calculated by Eckhart score of less than or equal to 3. Secondary outcomes were technical success, procedure duration, adverse events, IRP changes, barium column height at 1 month, and GERD incidence, which was assessed at 3 months. So the baseline parameters were recorded, and the primary outcome, clinical success rate was 96.3% in short myotomy, whereas 96.2% in long myotomy group, confirming its non-inferiority of the short myotomy. And secondary outcomes, procedure and safety, short myotomy was significantly faster. If you see, the median time for the procedure was only 61.22 minutes in short myotomy, whereas it took 82 minutes in long myotomy. Technical success was 100% in short myotomy, in only 96.3% in long myotomy, because one patient, the procedure was abandoned due to extensive fibrosis. And no major adverse events were reported, only minor adverse events of capnoperitoneum and mucosal injuries, which were comparable between both the groups. And esophageal function, which was assessed after 1 month, IRP reduction was similar in both the groups. Barium column height after 5 minutes was slightly lower in a long myotomy group, but the barium column height was less than 2 cm in both the groups. GERD incidence, only 14.3% of the short myotomy patients had GERD, that is acid exposure time more than 6%, compared to long myotomy group, which was 33.3%. But only half of the patients, among the 52 patients, only 26 patients underwent 24-hour pH study at 3 months. So they have concluded that short myotomy is as effective as long myotomy in achieving clinical success for achalasia cardia, and short myotomy has a significantly reduced operative time without increasing any risk, and GERD incidence was similar in both the groups. Strengths were, it was a first randomized controlled trial comparing short and long myotomy. Limitations, all procedures were performed by a single expert endoscopist, small sample size, and the study was not powered to analyze the difference between type 1 and type 2 achalasia, because majority of the patients had type 2 achalasia. Type 3 achalasia patients were already excluded, and only half of the enrolled patients underwent 24-hour pH study and a short follow-up period. So next one is risk of tuberculosis with anti-TNF therapy in Indian patients with inflammatory bowel disease despite negative screening, which was published in Arab Journal of Gastroenterology. Study was done in two institutions, Nizam's Institute of Medical Sciences, Hyderabad, and CHGS Medical College and KEM Hospital, Mumbai. Background is that anti-TNF agents increase the risk of TB reactivation, especially in an endemic country like India. So current screening methods for latent TB infection often fail to predict the post-treatment TB risk. Aim was to assess the incidence of TB in Indian patients receiving anti-TNF therapy and identify potential predictors of TB development. So study methods, it was a retrospective analysis of data from 2 tertiary care centers. 95 participants, 95 IBD patients, among that 83.2% were of Crohn's disease and 16.8% had ulcerative colitis. Inclusion criteria was that negative screening, TB screening, chest X-ray, HRCT and tuberculin test done before initiating anti-TNF therapy, and at least 6 months of follow-up post-therapy after starting therapy was required. Primary outcome was development of active TB after starting anti-TNF therapy. So the baseline characteristics were like the median age was 27 years, 62.1% were males, 82.1% received infliximab and 17.9% received adalimumab. The results were TB incidence 8.4%, that is 8 patients out of the 95 patients developed a TB after a median follow-up period of 9 months. The types of TB, 2 patients developed pulmonary TB, 5 patients had extrapulmonary TB, in that 3 had pleural TB and 2 had peritoneal TB, and 1 patient had disseminated TB. And predictors of TB development, in the multivariable analysis, they have found that only duration of biologicals, duration of anti-TNF therapy is the only independent predictor of TB risk. TB treatment outcomes, TB treatment was successful in all cases. 1 patient experienced IBD flare after stopping biologicals, but it was managed using corticosteroids. They concluded that Indian IBD patients have higher risk of TB despite negative pre-treatment screening, and longer duration of therapy significantly increases the TB risk. The current screening methods, chest X-ray, tuberculin skin test, fail to effectively predict the TB risk in this population. So recommendations were like more stringent protocol like HRCT and IGRA testing also to be included. Strengths of the study, it was a multi-center study and first study assessing real world TB risk in Indian IBD patients. Limitations, it was a small sample size and systematic post-TB screening was not done.
Now one question. So you said longer duration of IBD therapy, biological therapy. What duration was mentioned? After how long the incidence increases? That was
they have
mentioned.
not mentioned.
Not mentioned. Just duration was mentioned.
Longer duration had more. They have not mentioned any specific duration. Manto. Yes.
I'm not very sure whether Manto is being done to assess tuberculosis. Mostly CT chest and IGRA are being done, I think.
Next study was histological scores are poor predictors of short-term outcomes in acute severe ulcerative colitis, an observational study which was published in Digestive and Liver Diseases from AIIMS, New Delhi. Background and objective: the role of histological scoring systems in acute severe ulcerative colitis in predicting short-term outcomes remain unclear. So this study was done to evaluate whether histological scores can predict the need for second-line therapy or colectomy in acute severe ulcerative colitis patients. Study design: it was a retrospective observational study. Participants were 82 patients with acute severe ulcerative colitis. Median age was 36 years and 47.5% were males. Treatment and evaluation: all patients received intravenous corticosteroids. Sigmoidoscopy and biopsy was performed at admission and 3 histological scoring systems were assessed: simplified Gibbous scoring, Roberts histopathology index and Nancy histopathological index. The primary outcome was need for second line therapy, that is infliximab, cyclosporin, tofacitinib or colectomy within 28 days. Secondary outcomes were correlation of histological scores and steroid response on day 3 as per the Oxford criteria, or correlation between the histological scores and the endoscopic Mayo score, and correlation of histological scores among each other. So results: 32.9% of the patients were non-responders to steroids, 19.5% had a complete response by day 3, and 24 patients among these patients had required second line therapy. 16 received medical therapy and 8 underwent colectomy. So these were the baseline parameters which they assessed, the concomitant medications which they were taking, and their baseline laboratory parameters were also noted. Then predictive value of histological scores: they found that there was no significant association between histological scores and need for second line therapy or colectomy, or a response with steroid response at day 3. All 3 scores correlated well with each other, but not with endoscopic Mayo score. So strengths of the study: it was a first study testing histopathological scores in acute severe ulcerative colitis outcome prediction, and a well characterized cohort of 82 patients and detailed histological analysis was done. And they have also suggested that all 3 scores correlate well with each other. So a simple score like Nancy's index can be used for evaluation. Then limitations: it was a retrospective study and long-term colectomy risk follow-up was not done. Next study is discrimination of pediatric cryptogenic multifocal ulcerous stenosing enteritis from small bowel Crohn's disease and gastrointestinal tuberculosis, which was published in Indian Journal of Gastroenterology from ILBS, New Delhi. So background: CMUS is a rare small bowel disease that mimics Crohn's disease and gastrointestinal tuberculosis. Differentiating CMUS from these conditions is critical as treatments vary. The aim was to assess clinical, radiological, endoscopic and histopathological features of pediatric CMUS to establish distinguishing characteristics. So it was a retrospective study and 48 children with small bowel strictures were included. Inclusion criteria was for CMUS was unexplained bowel strictures with superficial ulcers involving only the mucosa and submucosa, chronic relapsing ulcers post surgical resection, no systemic inflammation and absence of other known causes. These 48 children, 13 cases were CMUS and 20 cases were gastrointestinal TB and 10 cases were small bowel Crohn's disease. The primary outcome was disease characteristics, differentiation from small bowel Crohn's disease and gastrointestinal TB, and the treatment response. So the results were: symptoms: CMUS had the longest disease duration, that is 22 months, as compared to small bowel Crohn's had median disease duration of 11.5 months, whereas in gastrointestinal TB it was only 5.5 months. And most common clinical presentation of CMUS was with subacute intestinal obstruction, obscure GI bleeding, and protein-losing enteropathy. 70% of the patients with CMUS received ATT previously without any response, and 54% of the patients were managed as refractory iron deficiency anemia before diagnosing CMUS. And small bowel Crohn's disease and gastrointestinal TB patients had more weight loss, fever, anorexia, and constitutional symptoms as compared to CMUS patients. CRP and inflammation. 90% of small bowel Crohn's disease and 80% of gastrointestinal TB patients had elevated CRP, but no one in the CMUS group had elevated CRP. So radiological differences, location of the ulcers. CMUS, all the patients had ulcers in the jejunum, and half of them had in the proximal ileum. In gastrointestinal TB, 85% had in the ileocecal region. Small bowel Crohn's disease, it was evenly distributed in the small bowel. Ulcer characteristics. CMUS had a superficial, circumferential, evenly spaced ulcers, whereas in Crohn's disease it was deep linear ulcer, and gastrointestinal TB deep circumferential ulcers. So photograph which they had given showing characteristic circumferential superficial ulcer of CMUS patient. And they have also assessed the treatment outcomes of CMUS patients. Immunosuppression alone was given in 70 patients. They had 75% relapse rate. Surgery was followed by immunosuppression. 100% had relapse rate, and 2 patients required repeat surgery. And surgery alone was given for subacute obstruction. Such patients, 67% were in remission. So they have concluded that CMUS can be differentiated from small bowel Crohn's disease and gastrointestinal TB by its longer disease duration, absence of systemic inflammation, and the characteristic ulcer patterns. Standard immunosuppressive therapy is ineffective, and surgery alone has shown better outcomes in their study. And genetic factors, SLCO2A1 mutations may contribute to the CMUS diagnosis. And further research in their study, they have done only this genetic mutation for 2 patients. In that, 1 patient was positive. Next is outcomes of underwater endoscopic mucosal resection for colorectal polyps, insights from Western India, which was also published in Indian Journal of Gastroenterology from Tata Memorial Hospital and Sir H.N. Reliance Foundation Hospital, Mumbai. Background, underwater EMR is an alternative to conventional EMR for removing sessile colorectal polyps, avoiding submucosal injection and reducing complications. Aims of the study were to assess the efficacy and safety of UEMR for polyps more than 10 millimeter and evaluate outcomes like complete resection, en bloc resection, complications, and recurrence rates. Study design, it was a retrospective study. Participants 159 patients and 261 polyps were included. Sessile colorectal polyps of more than 10 millimeter without any signs of submucosal invasion and no prior resection attempts. Procedure, polyps were submerged in water for better visualization and easier resection. No submucosal injection was done, and larger polyps whose size was more than 30 millimeter. Lesion margins were ablated to prevent recurrence. Primary outcome was en bloc resection rate. The polyp could be removed as a single piece. Secondary outcome was complete resection, which was histopathological negative margins and complications and recurrence. So results, en bloc resection was achieved in 91.8%. Piecemeal resection had to be done in 8.1% of the patients. Complete resection rate was 98.4%. And the most common polyp location was rectum, followed by sigmoid colon. Most common morphology was Paris 1S type. Histopathology, 51% had tubulovillous adenoma, 37% had tubular adenoma, and 21% had high-grade dysplasia. Complications, only 6.8% had complications. All were managed endoscopically. 3.8% had intraprocedural bleeding, which was controlled with cautery, electrocautery and clips, and delayed bleeding occurred in 1.5%, treated with coagulation or clips. Deep mural injury was found in 1.5%, and recurrence, that is, these patients underwent follow-up colonoscopy at 3 months, 6 months. So scar biopsy at 6 months, 3.1% of the patients had recurrence. And they have compared also the size of the polyp and the complications. So if we see that polyps more than 4 centimeter are having more rates of complications as compared to smaller size polyps, intraprocedural bleeding and delayed bleeding, they had more complications. And again, the rate of en bloc and incomplete resection, when the size was more than 40 millimeter, complication rates were found to be higher.
This is the last study.
Last one. Conclusion, underwater EMR is a highly effective and safe for sessile polyps more than 10 millimeter with high en bloc and complete resection rates. Complications were minimal, recurrence rates were low, and it can be considered as an alternative to conventional EMR, particularly for lesions less than 30 millimeter. Strength, it was first Indian study on underwater EMR. It had a large sample size. Limitations, there was no direct comparison with conventional EMR, and it was a retrospective study, and only 91 patients underwent follow-up colonoscopy or sigmoidoscopy. Thank you.
Thank you, Anna. That was a good collection of studies, and it was a good collection of studies. The evidence which you gave was good. I think that's also a little bit help us to change the practice. Any questions? I think. Postgraduates, any questions? Okay, then we will wind up. Huh? Thank you, Anna. Thank you.
Thank the chairpersons for the postgraduate session and Dr. Vamshi, moderator for the clinics in hepatology. We have just introduced this as a novel attempt to see if it benefits the postgraduates more. I hope that will be more interactive, and at least those postgraduates will be able to get the feel of being a panel, answer these questions more boldly. And in a couple of years, as you become consultants, I think you'll be invited as panelists or as a moderator, so you would know how to handle those questions. And also, it gives you a good opportunity for you to, face questions from the externals and see how it goes. So I hope that will be taken with further interest by the postgraduates in the sessions to come. And the other one, the journal scan, is again a small modification of what we have been doing earlier. Hopefully that gives us some input about what has happened in our own backyard, what publications have come in the last quarter. So at least we are a little abreast with what is happening now. So I'll move on to the secretary report. In the meantime, I think we'll come to the secretary report a little later. I'll request the CME session to start off. I'll request the chairpersons, Dr. B.S. Ramakrishna and Dr. Ilavarasi, to take the stage and conduct the proceedings, please. We'll come back to the secretary report a little later.
So it gives me great pleasure to ask Dr. Arun to talk to us about small molecules and IBD. We started with small molecules, and then we moved to large molecules, and now we're back to small molecules.
And Dr. Ilavarasi and Pirama, thank you for the opportunity. Today's session is to talk about an area which is rapidly changing the landscape of IBD management. So in the last decade, if we see what changed our clinical practice dramatically, it was something like hepatitis C treatment, which we thought was extremely difficult, but then became very easy with the advent of direct acting antivirals. So similarly, in this decade, small molecule drugs in IBD are changing the paradigms of our understanding of IBD and its management, forcing a change in the guidelines. So now today we'll try to deal with what these small molecule drugs are, how to classify them, and most of us are familiar with the safety and efficacy of these drugs in the context of ulcerative colitis. But are they effective in Crohn's disease also? And what are the evidence-based recommendations which govern the use of these molecules? And what are the emerging concepts and future perspectives of this class of drugs in IBD management? So what is a small molecule drug? A small molecule drug is an organic compound which is hydrophobic and having a low molecular weight. Usually it is less than 1 kilodalton. So because of these properties, it helps these drugs to freely diffuse across the cell membranes, and it can target intracellular molecules, thereby regulating cell function. So how do they differ from biologics? Owing to their small size, so they possess an advantage over biologics to target not only the extracellular components like cell surface receptors or protein domains attached to cell membranes such as glycoproteins, but also the intracellular proteins like different kinases, as they can easily cross the outer plasma membrane of the cells. They are very easy to synthesize by chemical reactions and are much cheaper compared to biologics. They are usually taken orally and designed to be metabolized from an inactive drug form to an active compound in the body. And unlike biological, they lack immunogenicity. So the small molecule drugs reveal their efficacy in IBD with the advent of JAK inhibitors. Mainly tofacitinib is what we are all used to, which initially came for treatment of rheumatoid arthritis. However, this class of drugs have expanded into 7 or 8 drug classes within. So among the JAK inhibitors, the well-known ones are tofacitinib, upadacitinib, and filgotinib. So though the initial reports showed efficacy in ulcerative colitis, upadacitinib has also proved to be efficacious and an option of management in Crohn's disease. Next came the class of sphingosine 1-phosphate modulators, basically which deal with lymphocyte trafficking. And in this drug class, ozanimod and amiselimod were evaluated for both Crohn's as well as ulcerative colitis, whereas etrasimod showed its efficacy in ulcerative colitis. Another class of drugs which are anti-integrins or anti-leukocyte trafficking agents, example of which is carotegrast, is being evaluated in ulcerative colitis. A new and unique drug class which targets this dihydroorotate dehydrogenase inhibitors is also found to be of value in ulcerative colitis. Another class of drugs, phosphodiesterase 4 inhibitors, example of which is apremilast, is being evaluated for both Crohn's as well as ulcerative colitis. Also SMAD7 blockers, toll-like receptor 9 agonists such as cobitolimod have also been evaluated, and newer classes of drugs are evolving. Obefacimod, the mechanism which upregulates miRNA and BT11, which has an entirely different pathway called LANCL2 pathway, are also being evaluated for IBD management. So now, when we talk about JAK family, it consists of 4 enzymes, 4 kinases: JAK1, JAK2, JAK3, and tyrosine kinase 2. While JAK1 and JAK3 deal with lymphocyte proliferation and homeostasis, JAK2 is involved in erythropoiesis, myelopoiesis, and platelet production. So the cytopenias which we see with this class of drugs are probably attributable to the JAK2 effect. And JAK1, tyrosine kinase 2, and JAK2 deal with innate antiviral responses as well. So the tofacitinib, which is the signature drug of this class, is a pan-JAK inhibitor with main action on JAK1 and JAK3 and lesser extent JAK2 and tyrosine kinase 2. So this drug found newer analogs which have increased selectivity because it was thought that the side effects of tofacitinib or pan-JAK inhibitors were due to its pan-JAK spectrum of action. So when upadacitinib came, it showed increased selectivity for JAK1 and it was thought to have lesser side effects compared to the pan-JAK inhibition. Filgotinib is another molecule which we will talk about in the subsequent slides. So tofacitinib, it's the one which we all know very well. So it's an oral small molecule JAK inhibitor for treatment of ulcerative colitis. It has a very rapid onset of action. It can reduce symptoms as early as 3 days. And efficacy and safety in ulcerative colitis were shown in 2 phase 3 induction studies of Octave induction 1 and 2 and phase 3 maintenance study called Octave sustain study and an open label long-term extension study of the same series. So in contrast, the studies in Crohn's disease were disappointing and primary endpoint of clinical remission could not be met in the initial trials. So subsequent development of tofacitinib for treatment of Crohn's disease was discontinued. Tofacitinib, in addition to being a treatment option for ulcerative colitis, was also tested for acute severe or fulminant ulcerative colitis resistant to steroids and anti-TNFs. So here a higher dose of 10 milligram thrice daily proved to be a rescue therapy, reducing the requirement for colectomies. So among what is more important about tofacitinib are its adverse drug profile. Initially there was a FDA black box warning suggesting an increased risk for major adverse cardiac events and venous thromboembolism. However, this has been withdrawn as the relative risk has been shown in analysis of most meta-analysis of trials with only 1.07 relative risk. And another common problem we used to face was herpes zoster infections, which could occur up to 11.3% cases. And this has prompted the recommendation to vaccinate all patients who are likely to receive tofacitinib before starting treatment with herpes zoster vaccine. And other adverse events which are commonly noted are increase in lipid levels, total cholesterol, LDL as well as HDL levels. Venous thromboembolism is a concern. However, we as a precaution, nowadays the standard practice is not to use higher dose of tofacitinib, that is 10 mg twice daily for over 3 months together. So cytopenias, like we mentioned, could be related to JAK2 inhibitions. However, these are quite rare. Risk of malignancies also are low. The Octave trials showed non-melanoma skin cancer as the most frequent cancer. In 6 patients, it was observed. So another point about tofacitinib is that it requires dose reduction since the excretion is 70% through the liver and 30% through the renal. So now coming to upadacitinib. So this drug is one of the most promising among the JAK inhibitor class. The efficacy in ulcerative colitis was established with U-Achieve induction and U-Accomplish trials, which looked at ability of upadacitinib to induce remission. So it showed 26% and 34% after 8 weeks of treatment compared with 5 and 4% placebo respectively. So in maintenance of clinical remission, U-Achieve maintenance study showed that 42% who were treated with a dose of 15 mg and 52% who received dose of 30 mg showed clinical remission after 52 weeks compared to 12% seen in the placebo arm. So, in addition to ulcerative colitis, it has also shown its efficacy in Crohn's disease. So, here the important trials are U-Excel and U-Exceed, which are phase 3 trials, where 49% and 38% of patients treated with 45 mg of upadacitinib showed clinical remission. U-Endure trial investigated upadacitinib in maintenance therapy, and here 37.3% remission rates were observed with a dose of 15 mg, 47.6% with 30 mg against 15% in placebo arm. So, in addition to this, 40% who received the 30 mg dose achieved endoscopic response. So, subsequently, Celeste trial was done in patients with moderate to severe Crohn's disease. In this trial, at week 16, clinical remission was notable in 6 mg group, 27% versus 11% in placebo. However, at week 52, the patients who received higher doses of upadacitinib, that is 12 and 24 mg, reported some serious infections. So, in addition to this, when we use upadacitinib in higher doses, lipid levels go up. So, there is a long-term open label extension phase to this trial also. This is likely to be completed and published this year. So, filgotinib is a selective JAK1 inhibitor which was proven to be effective in ulcerative colitis through selection trial, which established its utility in both induction as well as maintenance. So, 26% in the induction study A and 11.5% versus 4.2% in placebo in induction study showed clinical remission, and after 58 weeks, 37.2% of filgotinib patients received maintained clinical remission versus 11% in placebo group. So, there was also interest in this molecule for the treatment of Crohn's disease with the Fitzroy trial, which was a phase 2 trial which showed promise. However, the diversity trial which came subsequently, which is a phase 3 trial, failed to show efficacy of filgotinib to induce and maintain remission in Crohn's disease. So, this drug does not have an approval for use in Crohn's disease at present. So, in addition to this, there are a lot of JAK inhibitors in development. One of them is a drug called ivarmacitinib, which is a selective JAK inhibitor. So, AMBER-2 phase 2 trial studied its safety and efficacy in UC, and at 8 weeks, the clinical response was 46.3% compared to 26% in the placebo arm. Now, there is an ongoing study, phase 3, in ulcerative colitis. So, a phase 2 study in Crohn's disease also has been completed. However, the results are yet to be published. So, another oral gut selective pan-JAK inhibitor is izencitinib, which is in phase 2 trial evaluation for treatment of both ulcerative colitis as well as Crohn's disease. So, the Vibrato study, which is a phase 2A, phase 2B study, looking at utility of both brepocitinib, which is an inhibitor of JAK1 and tyrosine kinase 2, as well as rituximab, another JAK3 inhibitor, in patients with moderate to severe active ulcerative colitis. So, this is again this is showing some promise, and phase 3 trials are being planned for these two drugs. So, deucravacitinib is a tyrosine kinase 2 inhibitor. It's also being evaluated for ulcerative colitis and Crohn's disease. Pefficitinib, phase 2b trials for ulcerative colitis. So if we look at a meta-analysis which came in 2023, looking at all the randomized trials until then, we can see the pooled outcomes for JAK inhibitors as well as in ulcerative colitis as well as Crohn's disease. So though the numbers are difficult to read here, the ones in green are mean a significant improvement over placebo. Ones in red are mean there is no significant difference compared to placebo. So what we can see is that tofacitinib as well as upadacitinib are useful for induction of remission in ulcerative colitis. Similarly, for maintenance, again, tofacitinib, upadacitinib as well as filgotinib are quite effective. So in Crohn's disease, tofacitinib showed efficacy in eliciting clinical response, but not in inducing clinical remission. Upadacitinib is all green here. So this is the only JAK inhibitor approved for use in Crohn's disease at present. The bottom one is filgotinib. Again, it did not achieve endoscopic remission or response. So if we look at all the JAK inhibitors, what we can see is that the diamond is farthest from the median here for upadacitinib. So upadacitinib seems to be the most promising JAK inhibitor in practice at present, which may be useful not only for ulcerative colitis but also for Crohn's disease. So now coming to the next class of drug, S1P modulators, basically sphingosine 1 phosphate interaction with its receptor mediate lymphocyte trafficking through thymus, secondary lymphoid organs, circulation as well as tissues. So they generally work by making lymphocytes unable to exit the lymph node, probably preventing them reaching the sites of inflammation. So there are 5 receptors for this. So the initial 2 drugs which came in this class were osanimod, which was a selective agonist of S1P receptors 1 and 5, and the True North trial, which we will talk about again, showed its efficacy in ulcerative colitis. Etrasimod is a selective agonist of S1P receptors 1, 4 and 5. So the interest in this molecule came with OASIS phase 2 trial and its open label extension, which showed early and durable clinical improvements in rectal bleeding as well as stool frequency. So coming to the important trials in osanimod, in ulcerative colitis, the Touchstone trial is one of the landmark trials which met its primary endpoint of clinical remission at week 8 in 16% of patients who received 1 mg, 14% who received 0.5 mg compared to 6% in the placebo. So this clinical remission was maintained at week 32 in 21% of the 1 mg and 26% of the 0.5 mg group. So it also showed excellent efficacy in remission induction and maintenance as well as mucosal healing at 34% compared to 12% with placebo. So now the True North trial which we mentioned, it is a phase 3 study for both induction as well as maintenance of clinical remission. Osanimod could achieve induction in 18.4% and 37% maintained remission compared to 18.5% in placebo. The adverse drug reactions observed with this drug included elevated liver enzymes and bradycardia. So in Crohn's disease, the important trials which looked at the efficacy of osanimod are the Stepstone trial, which showed that 23% had an endoscopic response defined as a reduction in the simple endoscopic score for Crohn's disease at 12 weeks of treatment. Clinical remission appeared in 39.1%, which was defined as a CDAI score of less than 150. So subsequently, another trial, which was a combination of 3 studies, a 12-week induction studies and a 52-week maintenance study, and a 264-week open label extension study. So this is a phase 3 clinical trial which attempted to evaluate safety and efficacy of ozanimod in moderate to severe active Crohn's disease. So in this, the primary endpoint was clinical remission, patients with a CDAI score of less than 150. But the first induction study, which was completed recently, did not meet its primary endpoint of clinical remission. So the other results are awaited. So coming to etrasimod, after the OASIS phase 2 trial, 2 studies looked at its efficacy in ulcerative colitis. Elevate UC12 study looked at induction of clinical remission, which was 25% compared to 15% in placebo. Elevate UC52 study, which looked at maintenance of clinical remission, which was 27 during the induction phase, and during the maintenance phase 32% compared to 7% in the placebo group. So if we look at the meta-analysis in 2023, pooled efficacy, ulcerative colitis, we can see that ozanimod is all green here, and in Crohn's disease, the ozanimod trials were not reported here, but there was no other molecule which showed any significant clinical benefit. So now coming to another drug class. So this is a TLR9 receptor agonist. So this cobitolimod is a DNA-based immunomodulatory sequence which upregulates or activates TLR9, and this leads to induction of anti-inflammatory cytokines such as IL-10 and type 1 interferons. So this is available in a local application preparation, and it was evaluated in conduct trial in patients with left-sided ulcerative colitis as an enema preparation 250 mg. So 2 doses induced clinical remission significantly more than placebo, that is 21% versus 7%. So right now it is being evaluated for left-sided ulcerative colitis as a phase 3 trial. So now coming to another drug class called anti-leukocyte trafficking agents or anti-integrins. Carotegrast is the representative molecule here. It, like natalizumab, it targets alpha-4 integrin, though it is taken orally. So a phase 3 study was done in moderate ulcerative colitis, which showed 45% clinical response after 8 weeks compared to 21% in placebo arm. In this, the nasopharyngitis was the most observed adverse event, which was usually mild, and increase in WBC count was also observed. SMAD7 blockers generated a lot of interest because of its potential benefit in Crohn's disease. It's basically this mongersen is a drug which is an antisense oligonucleotide. That can specifically bind SMAD7 messenger RNA, induce its degradation, and upregulate TGF-beta1 signaling, which is anti-inflammatory in nature. So a phase 3 trial for clinical Crohn's disease showed no significant difference, and further studies have been discontinued for this molecule in Crohn's disease. Among all these small molecule drugs, this was the drug meant only for Crohn's disease. Phosphodiesterase inhibitors, apremilast is the recently developed PDE4 inhibitor. Basically, it blocks cyclic AMP degradation by binding to catalytic site of phosphodiesterase 4. Phase 2 trial in ulcerative colitis did not show much promise, but studies are being conducted in Crohn's disease as a combination with guselkumab. So this drug has adverse drug reactions such as nausea, diarrhea and nasopharyngitis. Now obefazimod is another unique drug with a different mechanism. It interacts with cap binding complexes and stabilizes connection of these complexes, which ultimately leads to enhanced production of microRNA. So in a phase 2 trial, it showed 35 and 70% clinical remission and clinical response respectively versus 11% and 33% in placebo groups. The endoscopic improvement was 50% compared to 11% group in the placebo. So this is a very promising result, and further studies in ulcerative colitis are ongoing. So this is a different small molecular drug which targets activated and rapidly proliferating lymphocytes by inhibiting the dihydroorotate dehydrogenase enzyme. This is important for pyrimidine synthesis, so proliferation of lymphocytes. So this inhibitor leads to a reduction of pro-inflammatory cytokines including IL-17 and interferon gamma, leading to an increased apoptosis of activated lymphocytes. So CALDOS 1 trial, which is a phase 2 trial done on moderate to severe ulcerative colitis, evaluated this drug, and the 30 milligram once daily dose demonstrated significant improvement in clinical remission as well as endoscopic healing. So the exploratory statistical analysis showed clinical remission at week 50 with 33.7% absolute improvement over placebo, and endoscopic healing was observed with a 37% absolute improvement over placebo. So BT11 is a new oral gut restricted first in class investigational drug for Crohn's disease as well as ulcerative colitis. This targets lanthionine synthesis like 2 pathway and immunometabolic mechanisms. Basically it supports regulatory T cell stability, so thereby upregulating anti-inflammatory mechanisms. So now moving on to the emerging concepts. So since this targeted therapy with small molecule drugs has shown a lot of promise, people have tried to combine 2 small molecular drug or 1 small molecular drug with another biological or 2 biological. So this is thought as a better option. However, whether it is superior to monotherapy in achieving the new target of deep healing is not certain. And additionally, the profound immunosuppression which might happen could make it unsafe. It may not be effective in all the group, and development of these drugs are quite expensive also. So this is another concepts looking at combining 2 drug targets in 1 molecule. So these are bispecific antibodies. These are mostly among biological groups, though the concept is being extrapolated for the small molecule drug classes also. So bispecific antibodies are molecules which can bind 2 different antigens or 2 different epitopes of the same antigen. So this is no longer just a concept. There are 3 bispecific antibodies approved for clinical practice. One for malignant ascites called catumaxomab, and for leukemia blinatumomab, and emicizumab for hemophilia. However, no drug has come from this class for the management of IBD. So now, where do we place these drugs, small molecular drugs, in the current management? What do guidelines say? So this is a 2024 living guideline update for moderate to severe ulcerative colitis management from the American Gastroenterological Association. So what it says is that we should use the most efficacious drug first, and it has classified which are the most efficacious drugs: higher efficacy drugs, intermediate efficacy drugs, and lower efficacy medications. So the higher efficacy medications, among them we can see osanimod, etrasimod, upadacitinib from this small molecular drug class, which shows how much acceptance it is gaining in the management of ulcerative colitis. So this is for therapy naive patients, and among patients with advanced therapies, tofacitinib, upadacitinib are shown as higher efficacy medications, whereas osanimod and etrasimod are shown as lower efficacy medicines. So what it means is that JAK inhibitors can be an option for ulcerative colitis both in treatment naive patients and treatment experienced patients, whereas S1P modifiers are generally useful for treatment naive patients, and it may not work very well in patients who have treatment experienced. Similarly, the ECHO guideline which came last year for Crohn's disease management shows that among the recommended drugs, upadacitinib finds its place both for induction and maintenance of remission, and so that is the only small molecular drug which has the recommendation for use in Crohn's disease. So concluding, the small molecule drugs are justified for use in treatment of ulcerative and Crohn's disease due to their lack of immunogenicity, comfort of oral administration, higher compliance, and rapid onset of action. Currently, they cannot be considered a panacea, and mean remission rates are only 40%. Their full potential will only be known in the coming years, and the promising real world feedback on use of small molecule drugs as first line as well as combination with either another drug or biological is showing a lot of promise and is likely to become the strategy for the near future to come.
Thank you, Doctor. Thank you for this exhaustive review, and also the kind of take-home message that they still need to mature a little before they can be widely used in the management of IBD, or as first-line drugs in management of IBD. Yeah. So, what's available here in India, and what do you think is likely to come?
Tofacitinib is available, sir. Tofacitinib, I think, is gaining acceptance for management of ulcerative colitis which are treatment experienced, as well as in newly diagnosed cases as a first line agent.
Okay. Any questions from the audience?
Have you used tofacitinib in a previous patient who's failed a biological therapy in your thing?
Actually, tofacitinib I have tried when there are no other options, because it's a drug which we can find out whether it is working or not in a few days. So in 1 or 2 weeks itself, patients report symptomatic improvement. So if it doesn't work, we can always stop them. So that way I have used.
Okay, if there are no questions, then we can move on to the next talk. So for the next talk, I invite Dr. B. Mahadevan, Senior Consultant, Global Hospitals, to deliver the lecture on disconnected pancreatic duct syndrome.
So good evening, everybody. Respected chairpersons, dear teachers and friends. So like to thank Dr. Param for this kind invitation. And after the exhaustive, I think, review by Dr. Arun, I think I'll be discussing one of the common and challenging clinical scenario, because I chose the topic because it's most often is overlooked or underdiagnosed entity in patients those who have acute necrotizing pancreatitis. And we all know that the diagnosis is often delayed. They come up with recurrent complications like fluid collections or recurrent pancreatitis, pancreatic endocrine or exocrine insufficiency. That's why I chose the topic. And before moving to the topic, I just show you some fast facts. The prevalence of disconnected duct syndrome is seen in 30 to 50% of acute necrotizing pancreatitis, and it's very. There other data which showed that patients who had walled up necrosis have almost 3/4 of them had disconnected duct. This data from AEG, and 1/3 of them had new onset of diabetes. So these figures are little alarming. And before going into the topic per se, I'll just show some of my case snippets. And this first patient was a 24-year-old girl. Actually, was a known case of hyperhomocystinemia. This was diagnosed by one of our registers. When she came with acute pancreatitis, she had anterior lens dislocation. And she had a stomachose, and she went into she developed a large pseudocyst at the 4th week, and she underwent cystogastroscopy. And the stent was left for 2 years, then it was removed. And 2 years later, she came back with again episode of acute onset of pain, that time which showed a stone in the main pancreatic duct. And she underwent ERCP, stone was removed, and she had underwent a minor papilla sphincterotomy also. Then after that episode, the pain was never subsided. Subsequently, she had multiple episodes of pancreatic pain, and mainly in the left upper quadrant and to the left loin. And she underwent again ERCP multiple times. So this was one of her image. You can see the pancreatic duct, stone was removed, and you can see the abrupt cutoff of the pancreatic duct, even pancreatogram contrast is not going beyond that. And this is her image. Actually, the stone disease initially presented as acute pancreatitis, then subsequently she had a stone. So here is a stone actually that it was removed by ERCP. This was a CT images was showing. This is a 2021 images. You can see dilated pancreatic duct, and you can see a small portion of pancreas with completely atrophied, and you can see a dilated duct. And this we didn't notice that actually. And subsequently, this is 2024 image showing the same dilated pancreatic duct, pancreatic parenchyma significantly atrophied, and you can see that every time when the CT scan reported as distal pancreatitis, it's only there are some fluid collection around the distal pancreas. You can see there are some fluid collection. You can see significantly there is a dilated duct, a portion of the duct. So this patient, this is the MRCP images. Basically, she had a disconnected pancreatic duct syndrome. Though she had acute pancreatitis, then she developed chronic. Then, even after, despite adequate drainage of the pancreatic duct, she had recurrent pain mainly on the left upper quadrant, and she had developed recurrent pancreatitis. So this is a very typical case of disconnected duct. The second patient is a 14-year-old girl. She had recurrent abdominal pain. She presented with 3-month symptoms with weight loss, and she had basically in 2022 she had a severe acute pancreatitis. She was managed in 2022. This was her chronology of illness. So at 0 weeks, she was admitted in ICU. At 4th week, she developed pancreatic, peripancreatic collection, underwent a percutaneous drain. And 4 weeks later, she developed sepsis. She underwent antibiotics were escalated. She underwent laparoscopic necrosectomy. Then she was, another 4 weeks later, she developed fungal infection. She took up for another surgery and peritoneal lavage, and she was discharged. The story never ends like that. Actually, she subsequently developed severe pain. So in that phase, she presented to us. This was her MRCP image actually. There was a thin rim of fluid collection around the pancreas, and there was collection just in the subdiaphragmatic area. So she went into every possible hospitals and consulted. and nothing could be done actually. Then 1 month later, she presented with fluid collection. So this was a thing which is good things happened to the patient. She underwent EUS guided cystogastroscopy. She is on follow-up for the past 3 years. She's yet to remove the plastic stent. This is a very typical clinical scenario. Often seen patient is managed by multiple surgical attempts and then land up in disconnected duct. The third patient is a 15-year-old boy, very recently managed. Actually, he presented with third week of at the end of the third week, presented with a huge abdominal pain with a cross distended abdomen. Underwent cystogastroscopy with the lumen opposing stent. Underwent multiple sessions of direct endoscopic necrosectomy. The last session was a very stormy course. Had developed sepsis because the necrosis are not in a single cavity. There are a lot of packets were there, and finally, actually, we presented with more and more pain. We wanted to get out of this. And this was a stent, in the plumbar stent. You can see the CT. This is a very typical disconnected duct. You can see there is a stent is there inside. You can see a dilated duct. So this is the dilated duct directly entering into the cavity with the upstream dilated duct. You can see the dilated duct which is viable. So again, this is a typical disconnected duct. The story not end because again, after all these episodes, again has come back with right upper quadrant pain, right loin, yes, again fluid collection. This is very typical common clinical scenarios. Again, we attempted to do ERCP, though there was some pancreatic contrast is entering. When we attempt to pass a wire was not going. Again, we went try with the EUS guided, but again, you see the stent already in the cavity after LAMS removal. We attempted to put some contrast, but again, it was failed. So all these cases will tell you that this is a very not an uncommon thing. Probably most of you would have experienced these kind of cases. This is basically for postgraduate and young gastroenterologists. Basically, this is a typical scenario of a disconnected pancreatic duct syndrome. This happens following acute necrotizing pancreatitis, not in interstitial pancreatitis. It happens in acute necrotizing pancreatitis. This is a typical scenario. The necrosis which involves not only the parenchyma, it involves the duct, main pancreatic duct, which leaves behind the excluded pancreas. This pancreas is still viable, which secretes a pancreatic juice. Then it goes into a release into the adjacent area, presenting with different consequences. So there are different nomenclatures. Disconnected duct is just an anatomical disruption, but syndrome is basically presenting with different complications. But pancreatic leak is a partial disruption. There are not only the acute necrotizing pancreatitis, there are other causes also, like blunt injury abdomen. You would have seen in children presenting with acute blunt injury abdomen with disconnected duct, following surgeries, and very commonly chronic pancreatitis because stone is blocking, because of increased intraductal pressure, duct blows out, and there will be a lot of leak. Not only that, there will be a fistulas into the pleural cavities. Many of you would have seen that. And malignancy also one of the causes for disconnected duct. And so as I said, that major reason for disconnected ducts in necrotizing pancreatitis is pancreatic necrosis involving the main duct. And some of the studies have shown that ERCP, which showed almost 44% of some form of ductal injury. And this is from Dr. Sham's center. Most often, whenever there is a walled-off necrosis, there is a high chances of disconnected duct. That should you to keep in mind. And their center showed almost 84% of the patient had disconnected, those who had walled-off necrosis. And this is a study from PGI, almost 77% of the patients had DPDS, those who have undergone EUS guided drainage. This is a very typical image. You can see a large necrotic collection with upstream dilated duct. And there is a viable pancreas. This is very typically of a disconnected duct. What will be the natural cause of this particular entity? Most of them, some of the patients know almost 70 to 80%. What the data says, they are asymptomatic, they may not come to us. And subset of patients, they may have a recurrent fluid collection. You do interventions, then they may come back, you remove the stent, or the surgeons do a necrosectomy, then they come back with recurrent fluid collection. Those who had acute necrotizing pancreatitis, you treated this patient coming back repeatedly, then you should think of a DPDS. Then there is a persistent fistula. Already somebody undergone a percutaneous drain. Again, there is a continuous fluid drainage through the fistula, then you suspect. Sometimes when these patients, these ducts can go for atrophy. The distal duct will go for strictures, and whatever the excluded parenchyma will go for recurrent pancreatitis. This is a very common scenario. This one of our patient had very similar clinical situation. Either they go for recurrent pancreatitis, end up in pancreatic atrophy, landing up with either diabetes or exocrine insufficiency. Diagnosis mainly based on imaging. You need to have a very good quality imaging. Mainly CECT is more than sufficient, mainly pancreatic protocol CT is sufficient. When you don't have get any adequate information, do an MRCP. You will know where the duct is disrupted, whether it is entering into the cavity or not. And endoscopic ultrasound also useful. ERCP hardly been done, regularly practiced. There are some diagnostic criteria for disconnected duct. This is way back in 2007, but it has not been widely used. So basically, these patients should have either 2 centimeter necrotic collection, like walled up necrosis, and there should be a viable pancreatic parenchyma. And when you do ERCP, there should be a contrast extravasation. The fourth thing is the pancreatic duct. By imaging, there should be entering into the collection. So I'll show you that some of the images. I think when you do an ERCP, there is a contrast extravasation. There is a 2 centimeter collection with the upstream dilated duct. And this is a duct which is directly entering into the cavity. These are only findings which tell you this is very typically of a disconnected pancreatic duct syndrome. So how do they manifest? Many of them will present with repeated pain. So they may have recurrent fluid collection, as we have discussed. Pancreatic fistulas, either when already somebody is placed as drain, they have fistulas, or sometimes pleural fistulas. Pancreatic ascites, very common in chronic pancreatitis. Patient can present with recurrent pancreatic pain, as we have mentioned, that endocrine exocrine insufficiency. This is usually whenever patients presents with walled off necrosis, often they'll go for a step-up approach. This is a standard of care. Either they'll go for a transmural drainage by using endoscopic ultrasound guidance. But the advantage is there won't be any external fistula, there won't be any pancreatic fistula, very shorter hospital stay. But they may need, when there is a necrosis, a lot of necrosis, may require multiple sessions of endoscopic necrosectomy, what you have seen in the earlier case. Some setup, when centers are not, EUS is not available, then they go for a percutaneous drainage, or in the early phase of necrotic collections, they may need a percutaneous drainage, or VATS also can be performed. And beyond that, there are no guidelines. So whatever the guidelines says when to place a stent and other thing, how to diagnose, how to follow up this patient, there are no guidelines are available. Even whatever the societies, they don't talk about disconnected pancreatic duct syndrome. There are only 2 things are agreed statements. One is MRCP is a preferred diagnostic modality. Second thing is endoscopic transmural drainage is indicated for infected pancreatic necrosis with the loss of MPD disruption. And each one will follow a certain practice. This is from AAG. This is one of the article they published. So in that study, what they are doing actually, following transmural drainage, they do MRCP after 4 to 8 weeks, and they do an ERCP for all patients. And they look for any ductal disruption, and they try to place a stent if there is any possible leak. And after that, they remove the metal stent. This is what they followed. Out of 274 patients, this is a large group of patients. Almost 94% had undergone ERCP. Disconnected duct is in 74%. Stenting was done in 12%, and recurrent fluid collection in 13%. And when you look at the management, sometimes we don't do anything, so manage conservatively. Not every patient require an interventions. If whenever possible, sometimes manage conservatively. Endoscopy, we all know that when there is a walled up necrosis, we'll do a transmural drainage, and we leave the plastic stents for indefinite period of time. There are no guidelines are available, but in my practice, what I do, I remove the stents 1 or 2 years later. And because there is a risk of stent, because the stents are not designed for living for longer time in the cavity, many times it become a foreign body. So I'll try to remove in a year or two. And this will prevent the recurrent fluid collections. And ERCP often fails because there is a complete disruption of the duct, and very difficult to place a guide wire. If we are able to place, we are lucky, but most of the time it fails. And last is a EUS guided pancreatico-gastrostomy in selected group of patients. Again, it's a very challenging because you will not have a longer duct. After guide wire placement, you need to dilate the tract and placing the stent. And revision of the stent is also again a big problem. You can't leave it for a very longer period of time. And I think many of you know this particular study, whether you leave a plastic stent following a transmural drainage. This is an RCT from AAG. They done their RCT in patients who have undergone ward of necrosis, the transmural drainage. One group received stent, another group no stent. The final conclusion was there are no difference, even you place a stent or not. There are no difference in the recurrent fluid collection. But lot of criticism about this, but many of them they follow their own method. But what I practice, actually I leave the stent because the chance of recurrent fluid collection. But this is what typical endoscopic pancreatico-gastrostomy by US guided in an appropriate cases. When these are failed, then the patient has to go to the surgeon. Either what they generally do, they do a distal pancreatectomy, and in case if the viable portion of the pancreas is available, then you have to go for a Roux-en-Y pancreatico-jejunostomy. So overall, what you need whenever patient comes with the disconnected pancreatic duct syndrome is not that actually when patient comes, you place a metal stent, send the patient. You need to discuss with the surgeon, whenever possible discuss with the radiologist. You need a multidisciplinary approach. Any patient who comes with a ward of necrosis. So always you have to discuss with your surgical colleague or radiological colleague rather than treat yourself. And you need to look for these patients are developing any complications, fluid collections, pain, but these things needs to be addressed. So with this, and another thing is new onset of diabetes. Those patients who have disconnected duct and with the recurrent fluid collection. This is one of the study from AAG. Those having recurrent fluid collections, they develop a new onset of diabetes. The important fact is, so whenever there is a disconnected duct in the proximal portion, mainly in the genu or the proximal body, the chances of diabetes is very high. We all know that this huge portion of the pancreas goes for atrophy, they develop a diabetes. So important thing, following any necrotizing pancreatitis, these you have to look for when there is a wound in the in the body or the proximal body or the genu. You need to look for the diabetes because sometimes they land up with the diabetic ketoacidosis. When there is a chance of diabetes, very less when there is distal ductus involved. So there are some still with a lot of guidelines and we treat patients. There are some unanswered questions. So when to do ERCP? In my practice, I don't do routinely ERCP. I leave the question to the chairperson and the audience because I feel that doing ERCP is not very easy when there is a lot of pancreatic edema and there is a lot of necrosis and disconnected duct is most often very difficult to place the wires. And second thing, leaving a stent. Again, there are no clear guidelines how long you leave the plastic stents or do you place a stent or not. And then when to intervene, whether to send the patient to surgeon or manage endoscopically. This is always debatable things. I'll leave it to the audience. With that, I would like to conclude my talk.
Thank you, sir, for that extensive cover on disconnected pancreatic syndrome, starting from basics and showing your own cases and the management protocol. So, any questions regarding the role of ERCP, as sir had pointed out, regarding the role of ERCP as a first line?
Dr. Madhavan here.
Yes,
Sorry,
sir.
Yeah. So very often when we do CT in our patients with acute necrotizing pancreatitis, we see the anterior surface of the pancreas is completely necrotic in the body.
Yes, sir.
And we always think that these patients will end up with a disconnected pancreatic duct. Do you have any thoughts on that? Because we don't really follow them up. We don't know what happens. I think many of them seem to resolve over time.
Actually, when patients are asymptomatic, when there is a ward-up necrosis, we are not going to address that actually. Some of the patients, because even you do drainage, it will not, it will not effectively drain. Sometimes it invites infections. When there are symptomatic collections, large collections, we just drain those patients. And some of the patients on follow-up, and many patients, what we think actually they will go for disconnected. The patient will be completely asymptomatic. So we don't know why some patients have a complete disconnection, and it depends on the anatomy where the duct is opened up, where it is get collected. That makes, how when we are addressing, even after stent placement, they will be completely all right. But when the collections are not in one place, it will be multiple places, it's very difficult to handle.
So we have done with the two discussions, the CME. So I thank the speakers for this insightful talk. And
so we'll start off with a little later for the secretary report, and then we'll follow up with a short quiz as time permits. So I think we'll all agree that we had a wonderful TNISGCon session and annual conference organized at PSG College of Institute of Medical Sciences at Coimbatore. Thank Professor L. Venkatakrishnan and his team for the successful conduct of this wonderful meeting. We had a dedicated postgraduate session for the first time, I think, for about 6 hours, which was also well attended and it was quite interesting, and it was good to have some offbeat topics which was of importance to the postgraduates. We had about 250 registered participants, and we had about 63 or 60 odd articles which were present as abstracts as well. So quite a few awards. I think we had 2 good orations. Professor Madana Gopal oration was delivered by Dr. V. S. Shankaranarayanan, Professor V. Balasubramanian oration by Dr. Matthew Phillip. We had a Rising Star Award and multiple awards for the best publications from Professor V. A. Mathan Award, and we had a endoscopy video contest, which were also which had good participation. As far as the research activities of our society, I think Plex study is over. It is in the phase of manuscript writing. Dr. Alagamai is working on it. The next proposed study would be on a multi-center study on hepatocellular cancer. Dr. Sumati from Stanley Medical College has taken the lead. A study protocol, the data collection pro forma, and the Google Forms are ready. I think it will be circulated shortly to all members who are willing to participate, probably for about 3 to 6 months, I think is what is planned. It will be mainly an epidemiological data collection to see the presentation, the age, the demographics, the stage at which they present. So it's more of an epidemiological study. I think we will share that data shortly with all the members. And there's another one suggestion that I would like to have from the participants here. Think regarding this CME and the postgraduate session, we just experimented with another new format this meeting. I was just wondering if we can have more inclusion, more participation by all the departments, where they take ownership of this meeting as well. Otherwise, I think more or less it becomes the secretary or the treasurer who is running around asking for participation from the esteemed members. If it is okay with all of you, with your concurrence, can the CME section, that is the last 1.5 hours, can it be organized by the medical gastroenterology or the hepatology department of either government medical colleges or the private institutions in turns? So in effect, I think that ownership will be by the concerned department, and they are free to choose the format for that 1.5 hours. It could be 3 short lectures, it could be quiz, it could be a panel discussion, the way they want. So if it is acceptable to all, then probably we can make an attempt and see if that will. My aim here will be to attract more participation from all the educational institutes. I find the postgraduates a little more this time, but I would like to have some more assistants, associate professors in the institutes coming around and taking part in the meeting. So I'm open to suggestions, please. Sure. I mean, if it is agreed, I mean, if they can take it up, it will be nice.
Next month, we'll give it to the Madras Medical College. Prem is here. You accept?
Yeah, accept.
Sure. So, I mean, we can try this for the next 3-4 months, see how it goes. If people are happy with this, then I think it will be nice. Otherwise, it just becomes only the secretary or, a few members who are trying to run the show with, with their own thoughts. I think this will invite more, participation and involvement from the colleges and the institutes. The key forthcoming meetings are in Chennai will be the GLTS, that is the Liver Transplant Society meeting from Global Clinicals, on April 11th to 13th. We have the scope from GEM Hospitals from May 30th to 1st June. And the TNSD will be running a biostatistics course mainly focused on the 2nd or 3rd year postgraduates. The course is for 7th and 8th of, June 2025. Sorry about the typo. So it will be a 2-day course. It will be pretty intense, mainly for focused on the postgraduates. Course director will be Dr. Usha Datta, who is our editor of Indian Journal of Gastroenterology, who has kindly consented to come around and run the biostats course. It will be quite useful, I hope, for the upcoming postgraduates. And if there are enough slots, we may also open up for people who are interested to participate in this as well. And the next month, there will be a 7th session of the ECME, which will be hosted from Tuticorin. Professor Selvasegaran has agreed to coordinate the meeting. The dates will be shared with you once it is confirmed. Thank you. I think you're done with the CME. I just close it shortly, then we'll run for a short quiz, which is more as another 10 minutes. So I'll see what we can take it through. So all of us understand the value of endoscopy in our day-to-day practice, but we'll just see how it has evolved and where we stand as a society. As a professional society, and how it has evolved. The trouble with looking inside the gut initially when it began was that it was very dark, and the gut is not a completely straight organ. So it's very interesting to see that the earlier attempts, like this one, in 1800s, they used what they called as a light conductor. They just used candle lamps as a light source to look into the cavity. It included the rectum. That was the only short thing that could live. But that was not met with any clinical utility. It is open for all, and it's anybody's guess. There are no prizes, but anybody can raise the hands, can just comment. When was the term endoscope actually coined? Any guesses? You have all 3-4 options. Anybody for the first? 1818, 50s, 1850s. Okay. 1922, 1900, 1922, quite a few hands. 1930s. Okay. So the first use of the term endoscope was in 1850s by this French physician, is Antoine Desormeaux. He coined the term endoscope. He wrote the first monograph on endoscopy, and his instrument is currently still in use as in the form of a cystoscope. Okay, and the interesting thing was he used it was not a candle. By this time they had moved to a gasogene. It was a mix of alcohol with turpentine, which was used as an illuminating source. So interesting thing that have come. This is a very famous diagram most of you must have seen. It's for a rigid gastroscopy. It's the same Kussmaul breathing that we know of. The same gentleman, Adolf Kussmaul, had attempted the gastroscope in 1860s, but it was scarcely noticed at the time. There was no publication, and it will be demonstrated. Demonstration will be done using a cooperative sword swallower. There are certain people who would be able to willing to swallow a sword. So those are the people whom they picked it up and tried to show a rigid scope down the tone. But the problem with this was there was poor visibility. The illumination was again with this turpentine and alcohol mix, poor visibility, and once they went into the stomach, it would be covered with gastric secretions, so they couldn't see. Any guess as to who invented the rigid sigmoidoscope? Any guess? Schindler? Hirschowitz? Any takers? Kelly? Okay. So the first institution was actually by a gynecologist by name Howard Kelly at Harvard University in 1860s. It was actually a rigid sigmoidoscope come a proctoscope. So that still held good till the early 1900s. So moving on, can you identify this famous personality whose invention changed the field of endoscopy? I'm not giving any choices here. Anybody, any guesses? Can be wild, can be anything. Hirschowitz? No. One more? Huh? Okay, so it's a very, very famous person, not limited to endoscope. Thomas Alva Edison. His invention of an incandescent lamp, an electric lamp, changed the way we started looking at things. So it gives us an illuminating source, an electric lamp, which could be used instead of using a turpentine, alcohol, or some candles. So that actually made a big change in the way the endoscopes were going to come in. So this was in 1879. Interestingly, in 1881 and 86, they started using this, attempting to use this in devising functional gastroscopes. But if you look at it, most of it, Mikulic's later gastroscope was being attempted, but none of them actually came to use till 1886, where they started using this called as Mignon bulb gastroscope, which was the first functional rigid esophagoscopy. Again, it was a rigid esophagoscope, but they had an electric lamp to give us the illuminating source. From 1880s to 1910, about 30-40 years, nothing much happened. Most of the attempted device designs did not come up to market. There was not much of interest among people. But in 1911, Joseph Elsner came up with the first functional gastroscope. So it had an angulated tip with a rubber obturator at the end, so they could enter safely into the stomach. And they will pull out the rubber obturator, then put in the lens to see what's happening in the scope. But that was limited by the inability to view because the lens would become dirty with the gastric secretions. So that was the limitation. That is when Rudolf Schindler, interestingly, I'll just share a short anecdote. He's a Jewish German who came up with the rigid gastroscope, but his new invention was that he could he set a channel where he could send a air out to clear the lens. So that made the visibility of the gastroscope much better. And then he devised, in 1930s, he devised a little flexible tip gastroscope. He was Jewish, so he was arrested following the Nazi purge, and he brokered a refuge into US. And he worked on till 1950s to improve the gastroscope design. And he established the American Gastroscopy Club, which was a very few people at Chicago. That was the forerunner for the American Society of GI Endoscopy. So you even have a Schindler Award if you go to the ASG thing that is in memory of this gentleman, Adolf Schindler. And esophagoscopy was initially under the domain of ENT because it was all rigid esophagoscope till 1950s when they start having this now. Can you identify this instrument? Any takers for the first? Yes, sir. There was a gastro camera. So initially it was up to 1900s where they were, okay, by this time they had entered into the scopes, they entered into the stomach, they could wash, clear the secretion, but there was no way they could document. Schindler and everybody used to have vivid artists, so he had to paint or draw the images himself to really demonstrate to the world. Now with gastro camera, it was developed in 1950 by Olympus, that I believe still has the image quality that they've made at this point of time still holds good. The snapshots probably are as good as it is right now. Any guesses on these three pioneers? Can you guess who, again, revolutionized the field of endoscopy? Who's direct, they were not one of them was a gastroenterologist, the other two are not, but their work revolutionized endoscopy. Any guesses on this, gentlemen? Looks Indian. This is a gastroenterologist whom you have named earlier. So he is called as the father of fiber optics. So his name is Narendra Singh Kapani. He was born, he did his undergraduation in Agra, went to do his PhD in Imperial College London, where he started working on his optical fiber transmission. It was in the early 1950s. So actually he was awarded a Padma Vibhushan in 2021 by Indian government posthumously. But his work was noticed by Basil Hershowitz and his colleague Larry Curtis. But at that point of time, they had problem with the fiber optics because they would lose the light. So here you see, this is Basil Hershowitz. Some of you have actually seen him, many of you in the senior colleagues have already seen him in person. But this gentleman, is Larry Curtis, they both collaborated in the 1950s. He was an MD resident at that point in time. He was an undergraduate second-year student majoring in physics. So they both collaborated to actually come up with a better design for optical fiber, and that was how they started using flexible gastroscopes. So now they were able to use an optical fiber, so they could bend the tubes, and they were able to go into different optics. So initially, even fiber optic endoscopes had side-viewing optics, not the front-viewing optics. So not many people or not many of the industry was interested in developing a flexible gastroscope, forward-viewing optics at that point in time. Notably, there was initial interest among the industry was pretty dismal. But all this gradually changed. Dr. Overholt was you can see in 6 years they started using flexible sigmoidoscopes, and by 1970 you had a full flexible colonoscope with a 4-way deflection. So that came up pretty recently. In 50 years back, we had a 4-way deflection, and by 70s they started doing polypectomies. So discovery of this device fetched a Nobel Prize in Physics in 2009. It again revolutionized and ushered in the modern era of video endoscopes. Any guesses? Yeah, it's a chip, but a little different. A little more? Exactly, it's a CCD. So these two gentlemen, Smith and Boyle, they worked in the Bell Labs. They invented and they patented the charged coupled device. So they were not working directly in the field of optics. They wanted to build up memory. They wanted to look at how to store memories for the computers. So they invented this, but this revolutionized the way so many of our current day-to-day practices, and which one of them has actually helped us with the endoscopic designs. So it was awarded a Nobel Prize in 2009 for their, it's almost 40 years down the line. So that in 1983, this was invented in the 1960s, 1970, but in 1983, Welch Allen mounted that company which produced the camera, mounted the miniature CCD onto the tip of a colonoscope, and they could get the images onto a remote television monitor, ushering in the era of video endoscopes. From 1980 till now, I think more or less we have had the similar scopy, but with little more improved version of what we are able to do. So ERCP, one of the first pancreatogram was achieved by a radiologist, not gastroenterologist. The surgeon did the endoscopic cannulation of the ampulla by William McCune in 1960s. And by 1970s, the biliary Everoff sphincterotomy and stone removal and everything had started. EUS was in 1976. They passed an ultrasound probe through the normal gastroscope working channel to get the first images of transgastric ultrasound looking at the cyst. And by 80s, the ultrasound transducer was fixed onto the distal end of the videoscope. They were able to, 1990s, the FNAs were started. Can you identify this instrument? Postgraduates here? Very good. So it was a Sonde intrascope. So small bowel lesion was still a dark area prior to Sonde intrascope. But in 20 years, Yamamoto developed a double balloon intrascope, and another 6 years you had the single balloon intrascope. So it's been a pretty fast management. This gentleman, any guess as what his contribution was? So cancer endoscopy. He is Gabriel Eden, Israeli scientist. He started using different CCD devices, metal oxidized, metallic oxide, I'm not sure about the CMOS, what the full form is, but they could miniaturize it and got better thing. They could use it in for a capsule. So 2001 started having the first capsule endoscopy. So these are all pioneers who all of you know. So I just want to stop with saying that the main milestones which changed the landscape of endoscopy was not actually from gastroenterologists. There was a lot of cross work, technical work from ancillary fields. Introduction of electric lamp as a light source was one major thing, so we could light up the gut. Optical fiber, which allowed the flexibility to come through, and CCD, which actually showed the era of video endoscope, have actually contributed to what we see as endoscopes now. Thank you so much for your kind time. And I think with that, I'll thank all the participants, moderators, the chairpersons, postgraduates who have taken part in this meeting. I thank the sponsors, the hotel, and the AV system for providing this wonderful meeting. I invite you all to go for a dinner. Thank you so much. We'll meet next month.